Good morning and welcome to the New York City Council hearing of the Committee on Health. At this time, can everybody please silence your cell phones? If you wish to testify, please go to the back of the room to fill out a testimony slip. At this time and going forward, no one is to approach the dais. I repeat, no one is to approach the dais. Chair, we are ready to begin.
Thank you. Good morning. I am Councilmember Lynn Schulman, Chair of the New York City Council's Committee on Health. Thank you all for joining us at today's hearing, where we will be hearing a number of introductions and resolutions. Before we begin, I'd like to recognize the following council members that are present: Councilmember Arreola, Councilmember Menon. We've been joined by the public advocate, and we have Councilmember Brooks Powers on Zoom. The first piece of legislation we will hear today is Introduction 29, sponsored by Majority Leader Farias. Traumatic brain injury may lead to serious complications if not treated, and is an especially acute problem for victims of domestic violence. Introduction 29 would address this issue by requiring the city to provide training to first responders and service providers on the connection between traumatic brain injury and domestic violence. I would like to thank the Mayor's Office to End Domestic and Gender-Based Violence for being here to testify on this important legislation. We will then hear legislation relating to health care for LGBTQIA+ and TGNCNBI folks in our city. Introductions 628 and 629, both sponsored by the public advocate, will require signage at city hospitals to inform patients on both the rights of and services available to transgender patients, and for DOHMH to report on the training providers regarding medical care for transgender and gender nonconforming people. Introduction 1056, sponsored by Councilmember Hudson, will require DOHMH, in collaboration with DOE and community-based organizations, to conduct annual LGBTQIA+ competency trainings for public school medical personnel. Amid relentless attacks on transgender communities nationwide, the Council is committed to ensuring that every New Yorker has access to the health care they need and deserve. This includes our city's vibrant LGBTQIA+ community, for whom we will never stop fighting. Next, we will hear a package of legislation relating to child care. This includes introductions 1041, 1042, and 1043, sponsored by Councilmember Sanchez. Introduction 804, sponsored by Councilmember Abreu, and proposed resolution 563-A by Councilmember Sanchez. Following the tragic death of Nicholas Feliz Dominici at a child care facility in the Bronx, it became clear that the city's growing opioid crisis has continued to worsen. Introductions 1041 and 1042 and Resolution 563-A will seek to address this by urging the state to tighten regulations and improve inspections at child daycare facilities, and by requiring the city to increase transparency around the training child care inspectors receive and the rights of parents whose children are cared for in these facilities. Introductions 804 and 1043 will require DOHMH to create programs aimed at training staff in child care facilities on the dangers of opioids, overdose prevention, and the use of opioid antagonists in child care facilities. I want to thank the mother of Nicholas Feliz Dominici for being here today to testify. There is no loss more tragic and more painful than the loss of a child, and we hope through collective action that a loss like this never happens again. We will then hear Introduction 1172, sponsored by Councilmember Holden and myself. Since the end of the pandemic, the number of pet surrenders has soared while the number of pet adoptions has plummeted. Many owners cite issues relating to financial strain, with Forbes advisor ranking New York City as the 6th most expensive city to own a dog. This bill would require DOHMH to set up a pet food pantry in at least one location in New York City for at least a year, so that pet owners in need can receive pet food at no cost. This will help decrease the number of pet surrenders and ensure that the city is more habitable for both people and our furry friends. I want to thank the animal advocates here today for championing this legislation. At last year's Health Committee hearing on the state of animal welfare, we heard your voices loud and clear. Our city is not doing enough for animal friends or for the people that care for them. This legislation envisions a future where pet owners are supported and where they don't have to make the heartbreaking decision to surrender their animal companion in order to pay their rent or afford groceries. We will then hear Introduction 895, sponsored by Councilmember Menon, and proposed Resolution 55A, sponsored by Deputy Speaker Ayala. Introduction 895 will require schools and child care programs to stock EpiPens, and Resolution 55A urges the state to pass legislation allowing for the presence of EpiPen devices on preschool premises. Anaphylaxis is a dangerous and deadly disease, but with the swift administration of epinephrine, its dangers can be largely mitigated. Increasing the prevalence of EpiPens in the places our children are cared for is a simple and necessary step to ensure their safety. Next, sorry, we're hearing a lot of bills today, so this is going to be a little lengthy. Next, we will hear a package of legislation relating to maternal health. This package includes introductions 1001 and 1284, both sponsored by Councilmember Gutierrez. Introduction 1146, sponsored by Councilmember Brooks Powers. Proposed Resolution 64-A, sponsored by Councilmember Caban. And Resolutions 867 and 868, both sponsored by the Speaker. These bills all have one goal in mind: alleviating the maternal health crisis this city faces. This council will not rest until every pregnant person, regardless of background, economic status, and community, can deliver their baby in the safest and most supportive conditions possible. We are also hearing a number of resolutions related to food safety. These include Resolution 290, sponsored by myself and the Public Advocate, which calls on the FDA to require warning labels on sugar-sweetened beverages. Resolution 442, sponsored by Councilmember Powers and myself, calling on the FDA to require chain restaurants to include added sugar information in the nutrition information available to customers. And proposed Resolution 294A, sponsored by Councilmember Stevens, which calls on the state to pass legislation to prohibit certain food additives, including substances that are generally recognized as safe, unless certain reporting requirements are met. And finally, we will hear Resolution 116, sponsored by Councilmember Hudson and myself, which calls on the state to pass legislation which would establish a medical debt relief fund. Such a fund would allow New Yorkers excuse me, to make a tax-deductible donation to those who are burdened by medical debt while filing their taxes. This fund would complement the citywide medical debt program introduced last year by the Mayor's Office to help eligible New Yorkers maintain financial stability by relieving some or all of their medical debt. I want to conclude by thanking all the bill sponsors for their hard work and leadership, the administration for being here to testify and answer questions, as well as the dedicated organizations, advocates, and members of the public. I also want to thank my staff, as well as the committee staff, for their preparation for this hearing. I want to acknowledge we've been joined by Councilmember Caban and Councilmember Farias. I'm going to skip around. Councilmember Farias, you want to talk about your bill?
Good morning. I'm Majority Leader Amanda Farias. Thank you, Chair Shulman and committee members, for the opportunity to speak today in strong support of Intro 29, legislation that mandates comprehensive traumatic brain injury training for first responders and launches a citywide public awareness campaign to bring visibility to one of the most invisible and devastating consequences of domestic violence. This bill is personal for many of us and urgent for our city. The Bronx and Brooklyn have the highest rates of domestic violence in New York City, and in the Bronx, in my district, is just second citywide with the highest rates of domestic and intimate partner homicides. These are the realities survivors face when compounded with challenges tied to housing, healthcare access, and criminalization. The status quo is failing our families. This bill offers a meaningful shift. We know that TBI among survivors of domestic violence is shockingly common and tragically misunderstood. A 2022 pilot conducted by Volunteers of America, Greater New York, and Safe Living Space found that 57% of screened shelter residents reported a head or neck injury, likely indicating TBI. When first responders are not trained to recognize symptoms like confusion, memory loss, or disorientation, these injuries are misread, not as cries for help, but as resistance or noncompliance. That leads to survivors being criminalized rather than cared for. VOA's pilot merely isn't just data, it's proof. When screening became standard practice in shelters, most survivors reported possible brain injuries. Intro 29 both scales this approach across every first responder and service provider, while also codifying this approach in law, making prevention and support consistent and required, rather than sporadic and contingent on the resources and reach of organizations like VOA. And this is not isolated. Across New York City, more than 230,000 domestic violence-related incident calls are made to the NYPD each year. That's over 600 calls per day. In 2024 alone, 137 people lost their lives to domestic violence, a number that has only grown. Between 2021 and 2022, domestic violence homicides increased by 29% citywide, including a 225% spike in Brooklyn and 57% in the Bronx. These are not just statistics, they are a crisis. That is why the work Volunteers of America and I are doing with Intro 29 is vital. It requires trauma-informed training for all first responders in NYPD and FDNY on the signs, symptoms, and long-term impacts of TBI, and public awareness efforts led by the Department of Health and Mental Hygiene and the Mayor's Office to End Domestic and Gender-Based Violence to educate the public, destigmatize brain injuries, and empower survivors. We also know the stakes. Research shows that 81% of intimate partner violence survivors report head injuries, 83% report strangulation, both causes of TBI. Untreated, TBIs can lead to PTSD, depression, insomnia, and long-term cognitive impairment. These are injuries we can't afford to ignore. This bill is the result of tireless advocacy, not just from my office, but from survivors, experts, and organizations like Volunteers of America, who have shown what's possible when screening and trauma-informed care becomes standard. Thanks to our collective efforts, Intro 29 now has a bipartisan supermajority of 36 co-sponsors, which has helped get us to this hearing today. And it took long enough, to be honest. But what is at stake is here to make systemic change. Passing this legislation means survivors will finally be seen, heard, and helped. It will ensure that our city responds with care instead of suspicion, support instead of silence. It will align our emergency response with best public health practices, breaking the cycle of injury and invisibility. Today, we have the chance to make New York City a national leader in addressing the silent epidemic of domestic violence-related TBI. I urge this administration to support this bill and my colleagues to sign on to Intro 29 if you have not done so already, for the women and families who deserve our protection and for the frontline workers who deserve the tools to save lives. Thank you.
Thank you. Before we move on, I want to acknowledge that we've been joined by Councilmember Narcisse and Councilmember Marmorato. I'm going to now pass the mic to the Public Advocate, Jumaane Williams, who will make a brief statement on his legislation.
Thank you so much. Good morning, everyone, and congratulations to all of my colleagues from their elections on Tuesday. My name is Jumaane Williams. I'm the Public Advocate for the City of New York. Thank you, Chair Shulman and members of the Committee on Health for allowing me the opportunity to provide a statement. Healthcare in the United States has really proactively taken into account the impact on transgender and nonconforming patients. Through legislation, we can build a more equitable and inclusive city that ensures accessible healthcare to our transgender, gender nonconforming, and non-binary TGNC and B New Yorkers. My two bills heard today would inform TGNC and B patients about their rights, the services available, as well as provide transparency and accountability. Donald Trump signed 6 executive orders directly targeting the TGNC and B community. More than ever, it is our duty to protect all people targeted by the current federal administration, including, but not limited to, our TGNC and B communities. Trump administration announced plans to end funding for the 988 Suicide and Crisis Lifeline specific to LGBTQ+ youth. In their announcement, they even omitted the T for transgender and Q for queer. This is not about anything else except cruelty and trying to erase people from actually existing. As the federal government moves forward with defunding and removing health care services for transgender youth, we must double down and protect anyone who receives or provides gender-affirming care. I've carried this legislation for several legislative sessions and hope this is the year they become law. Intro 628 requires the Department of Health and Mental Hygiene, DOHMH, to distribute and post signs on an individual's rights to be referred to by a preferred name, title, gender, and pronouns in city hospitals, and establishes guidance to encourage hospitals to list and conspicuously post the transgender-specific services and facilities and on its website. Intro 629 requires the Commissioner of DOHMH to report on training provided by hospitals to staff on care for trans and gender nonconforming persons. This should be available to every patient irrespective of gender identity, and is absolutely essential for TGNC and B individuals, many of whom have experienced barriers to services and oppression in seeking treatment. The discrimination and attacks from the current federal administration will exacerbate health disparities that already exist in treatment for the TGNC and B community. As of today, 27 states have passed laws banning some type of gender-affirming care for minors. 24 of those states ban puberty blockers and/or hormone treatments for transgender in minors. In Arizona and New Hampshire, the bans only apply to some of the extremely rare types of care for minors, and sometimes it is though extremely rare care that they use to stop all medical treatment. These are the many anti-trans legislations that have passed and all endanger the lives of so many people. More young people will be at risk if they no longer have access to the care they need. Currently, 940 bills within 49 states are under consideration that blocks trans people from receiving basic health care, education, legal recognition, and the right to publicly exist. 150 bills have passed, 729 of them are active, and only 96 have failed. And as I mentioned, well, I didn't mention, but there is an increase in suicide amongst transgender teens, so the erasure of that suicide hotline is even more cruel. New York City has taken major steps to protect transgender people, but they still face gaps and barriers within every system of government. With the hospital's rollback on gender-affirming care services, we must promote a system of support that reiterates the system's full commitment. I look forward to hearing from all of you today. Lastly, I'd like to highlight Councilmember, God bless you, Councilmember Schulman's Reso 290, which is calling upon the United States Food and Drug Administration to require warning labels on sugar-sweetened beverages. I'm a proud co-sponsor and believe that it's crucial we pass this resolution so that consumers are well informed. If I may, Madam Chair, I would like to just add a personal note on my bills, because the truth is I've always made sure I supported everyone's human rights and make sure I do what I can to help. But the truth is 10 years ago, I probably would not have been a prime sponsor of these bills. And I want to make sure I say that so that people who can hear me understand it's not enough to sit in the sidelines. You must step forward to make sure everyone is protected. And I always mention, as a black man, a Caribbean man, and a person of major faith, these communities have had issues with a lot of the communities that are under attack now. And I'm going to be honest, so people, when they hear me, they can help come on the same journey I've been in. I'm not always comfortable in every space that I'm in. That goes for houses of worship that I'm at mind. That goes for new restaurants, for places I haven't eaten. But I have decided a long time ago that my comfort is not more important than people's ability and right to live, love, and laugh like me in this planet. And I'm hoping that when people hear this, they understand that we have to be careful about where we put our marker of biases and why, because it gives other people permission to have their own markers that leave us out. And that the only way we're going to get through this is together. And the reason that some communities don't have health care is not because trans siblings have health care. It is because there are wealthy people who are benefiting from folks not getting the care that they need. And people know that it is harder to fight up. And so they want us to fight sideways. And so I'm hoping people hear this and join on the train of freedom and equity that includes everyone. Thank you.
Thank you, Public Advocate, and thank you for sharing that with us. I want to acknowledge that we've been joined by Councilmember Menon. No. Okay. I'm now going to read a statement from Councilmember Gutierrez regarding her legislation. Today, the committee is hearing two bills I'm proud to sponsor, each grounded in one simple principle: government should meet people where they are with timely, life-saving information. The first, Intro 1001, the New York City Text for Kids Act, would create a straightforward, low-cost text message system to remind parents of critical milestones in their child's development, like vaccine schedules, school enrollment deadlines, and more. Parenting in this city is already hard enough. A missed deadline shouldn't be what sets a child back. Modeled after the city's successful COVID vaccine texting program, this bill ensures families get clear, accessible reminders right on their phones. As one advocate said, wait, this doesn't already exist? Let's change that. The second bill, the Safe Pregnancy and Opioid Treatment Act, directly responds to Health Advisory Number 31, issued by DOHMH last year, which found that opioid overdose is now the leading cause of pregnancy-associated death in New York City. The data is devastating, and it demands action. This bill requires DOHMH to launch a provider education campaign on how to safely treat opioid use disorder during and after pregnancy with medically backed guidance from trusted professional organizations. It also requires that naloxone, an opioid reversal medication, be made available for free in neighborhood health centers along with instructions on how to use it. This isn't speculative policy. This is DOHMH's own research clearly stating the need. These are real deaths, real risks, and real opportunities to intervene with care, not stigma. Both bills are about delivering the right information at the right time to the people who need it most. Thank you to this committee for helping to move forward these bills. Now I'm going to ask Councilmember Brooks Powers to talk about her legislation.
Thank you so much, Chair. Can you hear me?
Yes.
Perfect. Good morning, Chair Schulman and colleagues. I'm proud to present Intro 1146, which would expand the newborn home visiting program and make it available in 75% of neighborhoods designated by the Task Force on Racial Inclusion and Equity within 3 years and 100% within 5. This program is one of the city's most effective low-cost interventions to support new families. It offers in-home and virtual visits from nurses, lactation consultants, and community health workers to provide education and referrals on infant safety, maternal mental health, bonding, immunizations, and more. It is a lifeline during those early weeks when new parents need support the most. But right now, access is limited. In Queens, the program only serves 3 zip codes despite the enormous need in districts like mine in Southeast Queens. That's unacceptable, especially when we know that Black women in New York City are nearly 8 times more likely to die from pregnancy-related causes than white women. This bill is about equity, prevention, and public health. By scaling this program to reach all tri-neighborhoods, and by holding ourselves accountable through clear reporting, we can reduce disparities and give every baby and family a healthier start. I thank my co-sponsors and urge my colleagues to support this critical step towards maternal and infant health equity. Thank you for the opportunity to give an opening statement on this important legislation.
Thank you, Councilmember. I'm now going to ask Councilmember Menon to make a brief statement on her legislation, Intro 895.
Thank you so much, Chair Schulman. In 2007, I was on vacation with my 3 children. We went out of state for vacation. We were in the state of Colorado. At the time, my 2.5-year-old son at a family dinner ate 1 bite of salmon, and he went into anaphylactic shock and couldn't breathe. I thankfully had an EpiPen with me because my elder son had a peanut allergy. We stabbed my son with the EpiPen and we called the ambulance. In the state of Colorado, they are mandated to have EpiPens on ambulances. They had to give him a second EpiPen because he couldn't breathe. When we finally got to the emergency room, the doctor said if we would not have had that original EpiPen with me, my son would have died. When we came back to New York, I found out that New York does not require EpiPens on ambulances. I spent 2 years advocating for the state to pass a law, and now EpiPens are in every single New York City ambulance. I also got a bill through the city council at the time that is now has a food allergy poster that is in every New York City restaurant that talks about cross-contamination. Now we have a situation with child care centers, and that is why I'm speaking about a bill I'm introducing today. The what if you do not have an EpiPen should frighten every single parent of a child with a food allergy, but it also should frighten every single elected official. EpiPens are the only treatment for anaphylactic shock, and they successfully reverse reactions in over 98% of cases. Notably, 25% of first-time reactions happen while the child is at school, indicating that families may not even know that the child needs an EpiPen until, frankly, it is too late. DOHMH oversees child care centers and their compliance with state law in ensuring EpiPens on site. In 2024, just 55 out of 2,200 child care centers, around 2.5%, did not have 2 EpiPens on site or were not properly stored. In addition, 25 centers, or 1.1%, did not have the necessary training requirements. Virtually all child care centers are in compliance with existing standards, which is very encouraging. That is why I'm proud to introduce Intro 895 to ensure all New York City public, private, and charter schools and child care centers stock 2 EpiPens on site in accordance with state law. DOHMH has already done incredible work providing childcare centers with EpiPens and training guidance. During its compliance inspections, DOHMH has documented multiple instances of childcare providers saving lives with EpiPens that the center had on hand. It is time to build on their efforts and guarantee that every single school and childcare center in New York City complies with state law, so nothing is left to chance. I want to end by saying I look forward to hearing testimony today from members of the public who are going to tell their personal stories of their child who did not survive because there was not an EpiPen. So their stories, as long as mine at the beginning of the hearing, should serve as a cautionary reminder about why we need to be proactive and vigilant. Thank you so much, Chair.
Thank you. Now I will pass it to Councilmember Caban to make a statement on her resolution.
Thank you. And I also just want to thank the public advocate. I deeply, deeply appreciated the words and the stories you shared. Thank you, Chair Schulman and members of the committee. Today I want to talk about an important issue in the fight to expand equal access to healthcare across our city. My proposed resolution, 64 of 2024, calls on the state legislature to pass and the governor to sign legislation to ensure community health centers are fully reimbursed for telehealth services. As we saw during the COVID-19 pandemic, telehealth is an essential tool of survival for millions of New Yorkers, particularly low-income communities, people of color, and people facing barriers to accessing in-person care. Today, however, despite their proven success, the frontline health providers who provide these services are being shortchanged by existing reimbursement rules. By supporting state bills in the Senate, 3359, and in the Assembly, 1691, we can help eliminate these funding disparities, ensure full funding for telehealth services, and protect community health centers that serve over 2 million New Yorkers. This resolution isn't just about dollars and cents. It's about guaranteeing access to care, advancing health justice, and ensuring that no one is left without medical services because they can't make it to a clinic. I look forward to hearing from stakeholders and the public on this crucial resolution. Thank you, Chair.
Thank you, Councilmember Caban. I'm now going to ask Councilmember Holden to make a brief statement on Intro 1172, of which I am a proud co-sponsor.
Thank you, Chair Schulman, for including the pet food pantry bill. Intro 1172 in today's hearing. Millions of New Yorkers are pet owners, yet economic uncertainty too often forces them into extraordinary difficult choice. An extraordinary difficult choice. Keep their beloved companion and face further financial strain or surrender their beloved pet. Our city possesses both the financial resources and infrastructure necessary to create a safety net for these pet owners, preventing them from having to make such a devastating decision. With the passage of this bill, the Department of Health would create and maintain a pet food pantry for at least 12 months, mobilizing our city's resources to protect both pets and their owners. The bill would additionally require the Department of Health to submit a report on the feasibility of continuing the program. So ideally, this would be hopefully in many areas of each borough. And initially we're doing at least one, but hopefully if this works and it takes off and it really helps a lot of people, then we could do it in several locations throughout the boroughs. Although this legislation establishes a temporary pantry, like I just mentioned, it creates a crucial foundation needed for permanent, accessible food pantries throughout New York City. Thank you, Chair, and again, thank you for including my bill.
Thank you. Now we will hear testimony from the Mayor's Office to End Domestic and Gender-Based Violence regarding Intro 29 in relation to requiring a training program for first responders and an awareness campaign regarding domestic violence-related traumatic brain injuries. Following testimony, the committee will ask questions about this legislation. I will now pass the mic to the committee counsel to administer the oath.
Thank you, Chair. If you could both please raise your right hand for me. Do you swear to tell the truth, the whole truth, and nothing but the truth, and to respond honestly to council member questions? You may proceed with your testimony.
Good morning, Majority Leader Farias, Chair Schulman, Public Advocate Williams, and members of the Committee on Health. My name is Jennifer DeCarli. I'm a Deputy Commissioner at the Mayor's Office on Domestic and Gender-Based Violence. I oversee the work we do at our family justice centers and other survivor support initiatives. I'm joined by my colleague today, Amira Aldadai, NGBV's Deputy Director of Training Programs and Initiatives. NGBV operates the city's 5 family justice centers, and we manage a robust portfolio of prevention and intervention programs through contracts with community-based providers. Our office builds capacity for agency staff and community members to identify and respond to domestic and gender-based violence through outreach and training. We also develop policies and best practices to strengthen the city's approach to these issues. We collaborate with city agencies, over 100 not-for-profit providers, community stakeholders, and people with lived experience to reduce barriers and ensure access to inclusive, culturally responsive services for all survivors. Thank you for the opportunity today to speak with you about Intro 29. Traumatic brain injury is a very serious, yet often invisible consequence of domestic and gender-based violence. Survivors may experience symptoms such as confusion, memory loss, dizziness, headaches, often without realizing these may be signs of a traumatic brain injury, which can go undetected without proper screening or medical evaluation. One of the most dangerous causes of TBI in domestic and gender-based violence cases is near-fatal strangulation. Research shows that strangulation occurs in nearly 38% of domestic violence cases and is one of the strongest predictors of intimate partner homicide. Even when there are no visible injuries, an act of near-fatal strangulation can result in devastating health consequences, including traumatic brain injury, stroke, carotid artery dissection, and long-term neurological harms. Recognizing the acute danger of near-fatal strangulation, NGBV launched a strangulation response roundtable in 2019 to coordinate a citywide cross-sector response to this issue. This multi-agency effort brings together hospitals, first responders, prosecutors, city agency partners, and advocates and survivors to enhance the city's response to survivors of near-fatal strangulation, and is supported by 3 subcommittees that meet between the roundtable meetings: Subcommittee on Healthcare, Advocacy, and Criminal Justice. Between 2023 and 2024, we delivered strangulation multidisciplinary trainings in all 5 boroughs, and we worked closely with each borough's district attorney's offices, NYPD, FDNY, domestic violence and gender-based violence advocates, and New York City Health and Hospitals to strengthen the system's response to incidents of strangulation. For example, we supported FDNY with a continuing medical education e-learning article for all EMS staff on identifying the risks and signs of strangulation, including the potential for traumatic brain injury as a serious outcome. Additionally, in December 2024, New York City Health and Hospitals published system-wide best practices guidelines for all of their emergency departments, standardizing care for survivors of near-fatal strangulation and ensuring timely medical and social service referrals. Looking ahead to 2025, we plan to expand training citywide, support New York City Health and Hospitals with their launch of new care coordination models like King's Care at Kings County Hospital. We plan to provide coordinated, patient-centered medical, psychological, and forensic support to survivors of domestic and gender-based violence at that model. I should say Kings County plans to provide that, including, and we plan to roll out tools to help survivors navigate follow-up care and make informed decisions after an incident of strangulation. We are also in the process of implementing strangulation response best practices in collaboration with H&H and FDNY EMS. We will continue partnering with each of the city's district attorney's offices to strengthen prosecution in cases involving near-fatal strangulation by helping them to build expert witness pools, to testify in criminal proceedings about the incident of strangulation, and provide ongoing training for law enforcement and legal personnel. For example, we are also currently working with NYPD's Domestic Violence Unit to develop a strangulation video to ensure that domestic violence police officers are aware of the serious health impacts of strangulation such as a traumatic brain injury. We will also work with FDNY to officially launch their non-fatal strangulation best practices response protocols. NGBV supports the intent of Intro 29. We continuously engage with our sister city agencies to review existing trainings and protocols so that they incorporate a trauma-informed, survivor-focused approach. We look forward to continued collaboration with the Council, our sister city agencies, and community-based partners and survivors to advance a coordinated, survivor-centered response to both near-fatal strangulation and domestic violence-related traumatic brain injury. Thank you for the opportunity to testify today. We welcome any questions you may have.
Thank you. I do have a few questions. One is, what agencies would be best suited to implement this training and awareness campaign, and how would they coordinate to achieve the goals of this bill?
So NGBV will support the sister city agencies named in the bill with those training efforts. We need to kind of discuss internally which agencies are best to lead those efforts. On the public awareness raising campaign, NGBV is more than happy to be involved and support those efforts. We've done a number of public awareness campaigns, and we look forward to working on that with our sister city agencies.
Great. Are there any existing trainings or outreach initiatives that already address this? And if so, how would this bill build upon them?
Yes, thank you so much for that question. As I mentioned in our testimony, for the last 5 years, we have done a tremendous amount of work on best practices for addressing near-fatal strangulation. There's a huge connection between incidents of near-fatal strangulation and TBI. We've done a number of trainings in each borough with hospital personnel, with NYPD, with DAs, to raise up the health impacts of near-fatal strangulation, which are mainly traumatic brain injuries. And so through those trainings, we've been doing a tremendous amount of work to raise awareness about the issue.
Thank you. Do any of my colleagues have questions? Nope. I want to also acknowledge that we've been joined by Councilmember De La Rosa. All right, we're good.
Thank you. Thank you so much.
Thank you. Next, we will move to testimony from DOHMH concerning the remaining introductions we are hearing today. Following their testimony, we will discuss intros 628, 629, and 1056, all in relation to care and training regarding LGBTQIA+ and TGN-CNBI New Yorkers. We'll try to group discussions of legislation with the administration by area of expertise. I'll ask DOHMH to come up to the table and the committee counsel to administer the oath.
Good morning. If you all could please raise your right hand. Do you promise to tell the truth, the whole truth, and nothing but the truth in front of this committee, and to respond honestly to council member questions? Great. You may proceed with your testimonies.
Good morning, Chair Schulman and members of the committee. I'm Dr. Zahira McNatt, Deputy Commissioner for the Center for Health Equity and Community Wellness and Chief Equity Officer at the New York City Department of Health and Mental Hygiene. Thank you for the opportunity to provide testimony today on several bills, including Intro 628, 629, 804, 1001, 1043, 1056, 1146, and 1284. First, I want to provide an overview of our maternal health programming. Maternal health has been and remains a key priority of the health department. This is a critical issue since we know that New York City mirrors the U.S. in its racial inequities in infant death, maternal death, and in life-threatening complications related to childbirth. In the fall of 2024, the National Center for Health Statistics published its 2023 maternal mortality data, which show that racial inequities have worsened since the COVID-19 pandemic. In 2021 and 2022, the U.S. maternal death rate for Black non-Hispanic women was about 2.6 times that of white non-Hispanic women. But in 2023, it rose to nearly 3.5 times higher. Although maternal mortality in New York City has declined since 2001, Black birthing people of all economic levels in New York City die in pregnancy and in postpartum at significantly higher rates than their white counterparts. These racial inequities are unjust, especially because for Black birthing people, 75% of these deaths are preventable, and many happen after discharge from a hospital. We are committed to seeing change, and this is reflected in our Healthy NYC goals, the city's campaign for healthier, longer lives. We aim to reduce the rate of pregnancy-associated death among Black, non-Hispanic birthing people by 10% by 2030. The department leads a range of programming to reduce inequities in outcomes and inequitable access to healthcare and social services. A few key programs which are critical to achieving these goals include the New Family Home Visits Initiative, which provides citywide access to high-quality home visiting services for new families with a focus on maternal mental health, chronic disease, and early childhood development. The initiative prioritizes first-time families in Tree neighborhoods, those who live in NYCHA, and those who are engaged with the Administration for Children's Services or living in a Department of Homeless Services shelter. New family home visiting programs include the Nurse Family Partnership, which is an evidence-based home visiting program that connects first-time expectant parents with trained nurses to promote healthy pregnancy outcomes, child development, and economic self-sufficiency and independence. We also have the Newborn Home Visiting Program, which was significantly expanded over the last few years. Newborn Home Visiting provides educational home visits conducted by community health workers to address health needs, safe homes, and safe sleep support, and connects families to social services that are essential to the well-being of parents, children, and their families. Home visitors are part of a multidisciplinary approach supported by nurses, lactation consultants, and social workers, as well as referrals to ongoing external clinical services. Additionally, with the support of City Council, our citywide doula initiative provides doula support during pregnancy, childbirth, and the postpartum period for families in Tree neighborhoods, a DHS shelter, or within the foster care system. The CDI also focuses on workforce development, training of community members to become doulas, and also supports hospitals in becoming more doula-friendly. These are a few initiatives among many which are critical to our work. The health department also addresses overdose risks among pregnant and postpartum individuals through a number of programs and partnerships. This includes the creation of educational materials, guidance for providers, and improving systems of care to better integrate mental health and substance use care for new parents. Last year, we circulated a HAN, or Health Advisory Network letter, to providers addressing overdose as the leading cause of pregnancy-associated death in New York City, and how they can support pregnant and postpartum patients and their newborns. Turning to the legislation, Intro 1146 relates to mandating a timeline for expanding the availability of the newborn home visiting program to all Tree neighborhoods. The program currently covers more than 75% of Tree neighborhoods, and our ultimate goal is to expand to all as soon as possible. A legislated mandate will not change our ability to expand in an evidence-based and effective manner. It is central to the effectiveness of this program to have nurses and healthcare workers from the communities they serve. We are facing significant workforce challenges in our efforts to reach the remaining neighborhoods, including the need for staff that speak Mandarin and or Cantonese. We must ensure that we have enough staff with the right skills to respectfully and effectively provide care for these communities, a process which inherently takes time. We are working as quickly as we can to staff up by filling our existing vacancies. We are working to address these challenges in our long-term efforts to reach full coverage at a pace that ensures effective and respectful care for disinvested communities. Intro 10001 relates to creating an automated text messaging system to provide participants with important reminders regarding children's health and development. We support the intent of this legislation. However, we have concerns about providing health and developmental milestone information in this manner. Developmental health information should come from the child's medical home, their pediatrician. Pediatricians are among the most trusted messengers for children's health for their parents and have the necessary medical history needed to alert parents about their child's tailored health needs. Pediatricians know the appropriate schedule of vaccinations and developmental milestones for a particular child and communicate that information through regular contact with the parents and child. The only information we could provide at the health department would be general guidance, which we do not recommend delivering in this manner. Every child is unique and has different medical recommendations. It may cause unintended stress to parents whose child may be developing more slowly than other children. Children do not develop at the same pace, and such text messaging may cause parents to think their children's health is at risk. It may also erode a family's relationship with their pediatrician. Additionally, our maternal health experts and network of community providers express concern that such a program could further erode trust in government among disinvested communities. The health department provides programs to assist families in health insurance enrollment to ensure all children have access to a pediatrician. We support the intent to better reach families with young children with information about utilizing city resources. The health department is not the best fit for coordinating across numerous city agencies on non-public health programs and topics. We look forward to partnering with the council and fellow city agency partners to better promote information on city services for children and families. We appreciate Councilmember Gutierrez and council staff for our conversations about this bill and look forward to continued engagement. Intro 1284 relates to an education campaign for healthcare providers about opioid use disorder during and after pregnancy and the provision of naloxone at the agency's neighborhood health service centers. We support the intent and appreciate recognizing the need to address overdose risk among pregnant and postpartum people. This is a complex and multi-layered issue that is a priority for the health department. Naloxone training and distribution is already available in our neighborhood health action centers. The health department is also working with the state and birthing hospitals to update guidance and create alternative pathways to support families outside of the child welfare system. We look forward to continued conversations with the council. Now I'd like to transition to the department's support for the health of transgender, gender nonconforming, and non-binary New Yorkers. The health department affirms that every person, regardless of gender identity or expression, deserves respectful, competent, and affirming health care. Yet transgender and gender nonconforming New Yorkers continue to face systemic discrimination in health settings, resulting in serious health inequities and mistrust of the health system. The mission of the health department is to protect and promote the health of all New Yorkers, including transgender and gender nonconforming people. We aim to address and eliminate the health inequities rooted in historical and contemporary systemic injustices and everyday discrimination. Essential to this work are the department's policy and protections, community engagement, and resources that seek to improve the health and health care of LGBTQ and transgender and gender nonconforming New Yorkers. In 2014, we paved the way for transgender New Yorkers to be recognized under the law by easing the requirements for obtaining a gender marker change on a New York City birth certificate. All people should have birth certificates that reflect their true gender identity, and these documents can be critical to accessing healthcare, employment, and other important services. Regarding the department's healthcare services, our clinics offer sexual health, tuberculosis, and immunization services. Many LGBTQ and TGNC individuals frequent our sexual health clinics, which offer low to no cost services for STI testing and treatment, expanded HIV services, including emergency PrEP initiation and counseling, and HIV treatment initiation for people diagnosed with HIV who would like to start treatment for the first time, as well as vaccinations, contraception, and many more services. In addition, these clinics offer overdose prevention and syringe availability services, and patient navigators and social workers assist patients in enrolling in social service programs such as substance use treatment and counseling. Our work to improve TGNC health goes beyond our clinic doors and into innovative programs. In 2017, New York City became the first city to issue an LGBTQ healthcare Bill of Rights, harnessing existing protections in local, state, and federal laws to empower LGBTQ New Yorkers to exercise their rights inside healthcare settings. This document, available on our website and at health centers across the city, reinforces that providers and their support staff cannot legally provide LGBTQ people with a lower quality of care because of their sexual orientation, gender identity, or gender expression, and tells people where to get help if their rights are being violated. In New York City, we protect and support TGNC communities, and we strongly oppose any policies that discriminate against anyone based on gender, identity, and expression. Turning to the legislation, Intro 628, which focuses on signage about transgender rights and services in hospitals. The department supports the intent of this legislation to provide a safe and welcoming clinical environment for all New Yorkers, including transgender and gender nonconforming patients. Given the scope of services available to patients by many providers and the frequency with which the services change, it would be challenging to maintain an updated list of the different services all New York City hospitals provide for their TGNC patients. Additionally, hospitals are regulated by the New York State Department of Health and not by the New York City Department of Health, and therefore the New York City Health Department cannot require hospitals to post signage in this way. Regarding Intro 629, requiring the department to report on training for medical care for transgender and gender nonconforming persons. DOHMH supports the intent of this legislation. However, we do not oversee medical training in the city, and we cannot compel hospitals to provide information about their training. Additionally, this kind of report would not advance the delivery of healthcare to TG and CNB patients, nor help to connect patients to trained providers, which is what this community needs. Lastly, the department does have the New York City Health Map, which lists LGBTQ affirming providers for community members seeking counseling, gender affirming care, primary care, and additional services. Intro 1056 relates to LGBTQ competency training for medical personnel in public schools. New York City public schools provide training on LGBTQ support and inclusion for school staff. This training includes curriculum on gender identity and anti-discrimination policies, inclusion and support policies, and more. School nurses and Office of School Health medical staff receive this training. We defer to New York City public schools regarding any specifics on the training content. The health department does not have the authority to mandate training for all medical staff in schools. Medical practice is regulated by the State Department of Health, and school staff training is regulated by New York City public schools. The New York City Health Department remains committed to protecting and promoting the health of all New Yorkers, including transgender and gender nonconforming persons and birthing people and their families. We are happy to discuss the legislation being heard, and thank you for the opportunity to be here today to address these important topics. We look forward to answering your questions. I'll now turn it over to my colleague, Deputy Commissioner Corinne Schiff.
Thank you.
Good morning, Public Advocate, Chair Schulman, members of the Health Committee. I'm Corinne Schiff, Deputy Commissioner for Environmental Health at the New York City Health Department. On behalf of Acting Commissioner Dr. Michelle Morse, thank you for the opportunity to testify today. For 220 years, the Health Department has worked to protect and promote the health of all New Yorkers. We are celebrating this birthday and our long history of excellence and innovation at a perilous time. The public's health is protected by an interconnected system of federal, state, and local partnerships. Yet, as Commissioner Morris has testified before the Council and alerted New Yorkers, 20% of the Health Department's budget comes from the federal government, and those funds are at risk. Around the country, state and local health departments are facing dramatic cuts, and the federal public health agencies are being slashed. The Health Department is facing this challenge, focused on our mission to serve New Yorkers and committed to advancing equity. Turning to the legislation under consideration today, Introduction 1172 would require the Health Department to establish a pilot pet food pantry program. The Health Department oversees a range of animal-related activities, including managing and caring for the city's population of owner-surrendered, abandoned, homeless, and lost animals. The department carries out these responsibilities by contracting with Animal Care Centers of New York City. The department appreciates the Council's interest in supporting pet owners who face financial stress. ACC offers a pet food pantry using grant funding when available, and we would be happy to work with ACC so they can share information with you about that program. The Health Department also monitors the health and safety of the city's child care centers, staffs schools with nurses working with New York City Public Schools, and addresses substance use disorders. Introduction 895 would require child care centers and schools to stock epinephrine autoinjectors. The department appreciates the council's interest in ensuring this life-saving medication is available for children with allergies. The New York City Health Code already requires childcare programs to maintain epinephrine autoinjectors on site and to train staff on allergy emergencies and administering the medication. The health department provides the autoinjectors to these providers at no cost. Also, Chancellor's regulations already require school nurses to be equipped with the epinephrine autoinjectors. Next, Introduction 1042 would require the department to report to the council on training for child care inspectors. We conduct significant initial and ongoing training for our child care inspectors and would like to work with the council to ease the administrative burden of reporting on this aspect of our work. Introduction 1041 would require the department to conduct an outreach campaign to inform parents about their rights in relation to child care programs. The department agrees that it's important for parents and other caregivers with children in child care to understand their rights and provider responsibilities. The department already provides parents with this information, including a flyer available in 13 languages, a website where parents can search for providers and review inspection history, offers a notification system so parents can sign up to receive updates when their child care provider has had a new inspection, and requires posting of a performance summary card. The department would be happy to further promote these resources. Introduction 804 would allow child care providers to request a free opioid antagonist kit from the department for every child and staff in their program. The department appreciates the council's interest in ensuring access to this life-saving medication. We want to assure New Yorkers that the risk to children in child care of exposure to opioids is extremely low. Nonetheless, the department conducted a one-time distribution of naloxone kits, providing one to every child care center and offering free training to providers. We trained more than 1,500 child care staff. The department is committed to a data-driven approach to reducing overdose deaths and distributed approximately 300,000 naloxone kits at no cost to community-based providers programs citywide last year, prioritizing settings where opioid overdoses most frequently occur or are witnessed. Given that there are nearly 500,000 children and staff in New York City's child care programs and the critical importance of ensuring this medication gets to those who need it most, the department opposes this legislation because it would require us to shift limited resources away from New Yorkers at risk. Lastly, Introduction 1043 would mandate the department implement a public awareness strategy regarding overdose prevention and reversal training and include the department's public health sanitarians and child care teachers as target audiences. The department appreciates the council's interest in promoting awareness among New Yorkers about overdose prevention and reversal training. As noted, the risks of overdose in a child care program are extremely low. The vast majority of child care providers offer children a safe and loving environment. Nonetheless, the department has already offered child care providers this training, and we continue to offer virtual trainings and a training video so providers can sign up at their convenience. The same is true for all health department staff, including our inspectors. We believe the department's current training efforts already meet the needs of child care providers and health inspectors, making this legislation unnecessary. The department recommends that we continue to use an evidence-based approach to reducing overdose deaths and focus our resources, including outreach efforts, on communities most at risk. Thank you for the opportunity to testify. My colleagues and I are happy to take your questions.
Thank you. I'm going to ask, I have one question, and then I'm going to give it to my colleagues, and then I'm going to come back. For Introduction 1172, you didn't say whether you were for it or not.
1172 is the bill about the pet food pantry.
Yeah.
We would like to follow up with discussions, including with ACC. ACC, unfortunately, was unable to be here. Today, I did speak with CEO and President Risa Weinstock yesterday. She had a commitment conflict, but she's happy to speak with you. So given that there already is pet food pantry resources as part of ACC's surrender prevention program, we'd like to follow up with discussions first.
Okay, thank you. I'm going to ask the public advocate.
Thank you very much, Madam Chair. Thank you, Dr. McNatt, for the testimony. One of my questions around 628 and 629. So, most of them will be together, the questions. So 629, you said you support the intent of this legislation. I'm assuming you mean the intent of providing some sort of report. And 628 says the department supports the intent of this legislation to provide a safe and welcoming clinical environment. Do you support the intent of providing type of signage that the bill is calling for?
Thank you so much for the question, Public Advocate. So we do support the intent of the legislation around making signage available. We just don't have the regulatory authority to make that happen in New York City hospitals.
So who has I think, and it was a similar answer to the reporting. So who has the power to require signage and require the type of report?
The New York State Department of Health.
Only the New York State. So you're saying that the city can't, forget about the agency. You're saying the city council can't require that DOH and MH or H&H provide this in public hospitals?
Thank you so much for the question. I can't speak knowledgeably to what the City Council can mandate within the New York State or New York City hospitals, but can only clarify that New York City Health Department doesn't have that authority.
So if this bill passed, wouldn't it give you the authority?
That's an interesting question. I don't believe so, but happy to follow up.
Okay. And then in the testimony it says the report would not advance the delivery of health care to TGNC and B patients, which was interesting to me. Because I know we listed all the things that are already available. This legislation came directly from advocates and communities, so they're experiencing in real time what already is there, and their recommendations were these things would make it a little easier and more helpful for them to get the services needed. In a tough time, they seem to be baseline stuff for me. So I was interested to see why you thought it would not help advance the delivery.
So I think we're referring to Intro 629 on the medical training report. And I think for clarification, it's an understanding that it's important for medical providers to be trained in this way, and that New York City hospitals may be doing some of that in some formats, and the health department is doing this kind of training for our own staff. But that the report in itself may not tell community members where's the best place for them to seek care. So some of the tools that the health department has created that helps with that particular issue, I mentioned in the testimony the New York City Health Map, which is a health service directory that serves as a vital resource for those seeking safe, accessible, and high-quality health services tailored to their needs. This online directory features a diverse network of New York City providers. The LGBTQ directory is designed to help individuals make informed decisions about their health care by highlighting providers with a demonstrated commitment to cultural competency and inclusive practices. So we have several more examples, which I'm happy to share, that I think help community members know where are the safe, affirming places to go. And so the report that you're describing can be valuable, I think, for folks within the political space, but may not be valuable to the user who's trying to figure out where they should go in New York City to get gender-affirming care.
I see. Okay, now that's helpful. I didn't view it as being user-friendly for the patients. I viewed it as the report would help political leaders make adjustments and recommend adjustments, and the hospitals themselves make adjustments based on what the reporting is. So thank you for the clarification.
Thank you.
You mentioned training that's already existing. Does that training already exist, particularly for TGNC and B, with those clientele in mind, reminding folks that they have to use preferred pronouns and names and titles and such?
Yes, thank you so much for the question. Particularly within the health department, we have a training that's in partnership with New York City Unity Project. We've partnered with a consulting firm called Trans Equity Consulting to develop an LGBTQ cultural competency training for health department sexual health clinic staff. And so that training covers language, key health considerations, and best practices for providing affirming care. We also provide other sorts of trainings in the health department and workshops around solidarity, knowing that we want our staff to know the basics and important information, but we also want our staff to practice solidarity in real time with transgender and gender nonconforming community members and patients. We have an LGBTQ ERG, or Employee Resource Group, that has also provided an affirming space to support staff and to help inform the kinds of training and education that should happen. So those are just a few examples of training inside the health department.
Thank you. And my last question is, which staff must participate in those trainings, and how do you evaluate their efficacy?
Thank you so much for the question. So depending on the focal area, so the example that I gave were for all staff that work in our clinical settings in the sexual health clinics. So it's targeted for the staff that provide particular services in that domain. Different trainings are targeted to different staff depending on where they're providing their services. And then some other solidarity-related work and programming is also optional for folks to continue growing and building their own ability to stand in solidarity with transgender and gender nonconforming folks. Based your question on evaluation, I will have to get back to you on the process of evaluation for the different trainings and some of the outcomes.
Okay, thank you.
So much.
Thank you for answering the questions. I look forward to working with everyone to see what we can do about these bills, particularly this population. Thank you.
Thank you so much.
Thank you, Public Advocate. I want to acknowledge that we've been joined by Councilmember Feliz and Councilmember Sanchez. Councilmember Sanchez.
Thank you so much, Chair Schulman, and thank you to the administration for sharing your positions on the bills. I just have 4 specific questions. We know that these bills are inspired by the horrible tragedy that took a 1-year-old child from us after exposure to fentanyl in daycare. So regarding Intro 804, shortly after Nicholas's passing, then Commissioner Vassan had noted that child care inspectors had not been trained to look for fentanyl and said, quote, maybe we need to start. In your testimony, you state that the risk of children's exposure in these settings is very low, but that you nevertheless conducted a one-time distribution to child care staff already. You state that you oppose the bill since it would shift limited resources away from New Yorkers most in need. Can you first share what the cost was of that one-time distribution? And second, most importantly, if not through making adjustments like Intro 804 would require, in the 650 days since Nicholas's passing, what has DOHMH determined could prevent a similar tragedy in the future?
Councilmember, I want to start by acknowledging, as you just did, the extraordinary tragedy that took Nicholas's life. And we've discussed at a hearing before how the death and that criminal activity was devastating, I think, for all of New York City, and certainly for our staff. I spent many days afterwards meeting with our child care staff, our inspectors who visit these centers, and it was difficult, heartbreaking for all of us. They are a team that is really dedicated to coming to work every day to promote safe environments for children, and we all felt that loss. We did do a distribution to child care programs, 1 kit for every program. The bill, as we read it, is 1 kit for every child and staff in the program. So that's our concern, is that's a lot, that's about 500,000 children, children and staff. So that's really where we're talking about the resources. I don't think we have the cost of that one-time distribution, but we can get that back to you. But I did want to clarify the distinction that we are making there. And as to your question about changes that we made, and the comment by Dr. Vassan immediately after the tragedy, we have implemented additional training for our staff. Our staff are conducting health and safety inspections. They're not law enforcement, but we have conducted trainings with NYPD to heighten their instincts, heighten the instincts of our staff, so that if they, particularly around illegal drugs and drug paraphernalia, so that if they observe things, they will have a greater awareness and be able to immediately escalate those. And we've had ongoing conversations to strengthen our relationships with NYPD to make sure that we're able to get a rapid communication with them.
Thank you. Chair, if I may, the family is coming in a little while, and I'm going to share my remarks because it's really for them when they arrive. But I just want to thank you, Deputy Commissioner, because that is one of the biggest asks that Nicholas's mom and dad had for us as city leaders, to make sure our inspectors are trained to look for those signs. So from the bottom of my heart, I have goosebumps. I want to thank you because that's something that they asked for. And if just a quick follow-up on that training, you mentioned that there are barriers, but this kind of thing, knowing that the department is being responsive is really helpful. Could you just share, just my final question, what the barriers are that you described to reporting on what the training is that the inspectors are receiving?
Yes, of course. So this is about the bill that would require us to do a routine report to you about all of the training that we do for our inspectors. So really the concern is we do so much training with our staff. So there is initial training. Our inspectors are college graduates with 30 credits in the sciences when they arrive, and they go through about a 4-month training program to learn what all of the regulations are, learn, of course, how to use their equipment, what they're looking for when they do these inspections. They are follow senior inspectors and then are shadowed by those senior inspectors, and only when they're through that are they sort of launched on their own to do those inspections. Then we have ongoing training throughout the year, training in customer service and conflict resolution, training to heighten their instincts, as I mentioned. And then as health department employees, we have first mandatory trainings that we all take as city employees, and then we also have wonderful opportunities as health department employees for ongoing professional development. And there are opportunities for our staff at every level to take those trainings to advance their skills. And that is not something we necessarily track, optional trainings that staff can take. So those are the sorts of burdens. I really want to emphasize that we want to spend our time focused on maintaining these safe environments for children. And so I want to just be sure that we're fulfilling the need that you have to understand the training that we do without taking so much time away on reporting.
Thank you. Thank you so much, Chair.
Sure. Councilmember Holden?
Thank you, Chair. Deputy Commissioner Schiff, you mentioned that ACC runs a food pantry, a pet food pantry. Could you tell us about that a little bit?
As I said, unfortunately, ACC was not able to be here, but they did ask me to share that they would like to follow up with you and the chair, I know you're a co-sponsor, so that they can share the details about that program.
Yeah, but that you just punted to them. This is a bill that we introduced, and we want to get your opinion on, and you're saying check with ACC. That's not how it works, Commissioner. I just want to talk to you about the program. Do you know how many locations that they have?
I don't know where the ACC offers the pantry, but I can say that our position on the bill is that we would like to share those details with you so that we're sure that this is something to move forward with.
But do you agree that there's a need?
My understanding from ACC is that the pet food pantry is an important part of their surrender prevention program. As you said in your opening comments, there is financial stress that pet owners experience, and sometimes they are faced with that heartbreaking decision of whether to relinquish a pet because they are facing hard times, and it's a moment
yeah, we
when
know
they
we
can't
know that.
afford
But
it.
what I'm asking you is there's a need for this, but do you know how many locations that ACC has for the pet food pantry?
I don't know how many locations they have.
One in the Bronx. And, I'm envisioning a mobile pantry, possibly, which would go to the boroughs. If you have one location in the five boroughs and 8.5 million, many of these people are pet owners, and if you have one location in the Bronx, it's not going to work. It won't work. If you have locations in every borough. So that's why I'm asking that if the health department can come up with some ideas and we can talk about it, but I think a mobile pantry would be, doable. I think we can get donations from various sources, but I think this is where we need to set up, some kind of need, and not just, because I checked, and again, I checked with the Mayor's Alliance for New York City's Animals, and you get a dead end. It says we have a pet food, there's a pet food pantry, but then it takes you to the one location in the Bronx of ACC. They have one location. And then it says food banks in New York City could have, depending on donations, could have them. So there's not really something consistent. So this is what I'm asking, is that we set up something that is more extensive, that is, and it would be a pilot program. It would just be maybe initially one location where health department runs, not with ACC. ACC can do it on their own, but I'm asking that we set up something, because they have limited resources, and I can't even get them to do adoption programs with their mobile unit because they only have one, and many times it's not staffed. So that's why I get a dead end on that. But in the food pantry, there's a huge dead end if you try to look for it. So that's why I'm asking that, and this hearing, which we're obviously we want to talk about this bill, but you don't have the information how extensive this is, and if you're willing to set something up, or if you're willing to talk to us about it. So I think we need a little bit more research, especially at a hearing, like how extensive, how many people are served by this ACC program, and how could the health department help us with this?
Happy to get back to you with ACC. I understand your bill is a pilot program and would be for a year and then for us to assess.
Right, and again, I'd rather not include ACC because I know that we're going to just put it on them to do all of this without the additional resources. That's a problem. So I just know we're headed for a dead end. So I think mobile, some more. If we had some, like I mentioned, mobile pantries or some other ways to set up. There's some good ideas out there. But when I research it, I keep running into a dead end. Thank you, Commissioner.
Thank you, Councilmember, and I echo what Councilmember Holden said. And the other thing, too, is that there's a presumption that people know about ACC. This is for just the general public, older people and all of that, that we have a place where they know that they can go for this. So I just wanted to mention that. Councilmember Menon?
Thank you so much, Chair. So just a couple questions. Despite home-based child care centers falling under the Office of Children and Family Services, my office has heard some home-based child caregivers are not aware of Elijah's Law or have language barriers that limit understanding of Elijah's Law and its specific requirements. What in your recommendation can the city do to address this situation and ensure there is more awareness of this life-saving law?
So Elijah's Law, I believe, is the New York state law that applies to the home-based programs. I had not heard that home-based providers are not aware. That is disappointing to hear, and I will be sharing that with OCFS, which does that outreach to their providers. OCFS, as you just noted, is the home-based programs are state regulated. They are under the auspices of OCFS. OCFS does contract with the health department to implement those regulations. They typically do the outreach and education to their regulated providers, and I'm going to follow up both on the general awareness and on the language access issues.
Great, thank you. And can you tell us what you're specifically doing to encourage the use of an appropriate weight-based epinephrine delivery system? Obviously, that's something that really matters, the child's weight, and so what awareness are you doing around that?
So for the city-regulated sites, where the health code rule already applies since 2018, requires these child care programs to have 2 epinephrine autoinjectors on site at the appropriate dosage, and the training that they're required to, and they are also required to take training. The health department provides the epinephrine autoinjectors to the city sites at the appropriate dosage for the children at that program.
And how often are you checking in terms of expiration date?
So we will replenish them. So they are sent out. We know the expiration date, and so we continuously send them so that they are, the requirement is unexpired epinephrine autoinjector on site. And so we, as part of our efforts to make sure that the programs have this life-saving medication, and I really appreciated the story that you told. I've had a similar story with my child, and it is terrifying. And so it is part of our program to make sure that they have an unexpired epinephrine autoinjector on site. We continue to provide those on the schedule.
And so when the child is not in the child care setting or at school, what can we do to raise awareness to parents about food allergies? Because like the story I told or the story that countless parents had where they don't know that their child has a life-threatening food allergy. Now, of course, and I mentioned to you the efforts I did to get the EpiPens on the ambulances, but we know that children are often in settings where there's not an EpiPen readily available, and unfortunately, minutes literally matter. What can be done to raise awareness in general on this issue?
One of the things that was so important to us when we brought this proposal to the Board of Health was just what you said. Parents of young children, they haven't had the opportunity to identify that their child has a life-threatening allergy. Sometimes the very first occurrence is at childcare, which is why we've provided the Epi auto-injectors for childcare programs. I think it's an important question that you ask, broader than childcare. Your bill that makes these, that you referenced about allergy posters in food in restaurants is another opportunity for education, but I think you're asking a broader question about allergies and beyond childcare, and I think that's something that we could think about and get back to you.
Great, I would appreciate that. Thank you very much. Thank you, Chair.
Okay, thank you. I have a few questions to ask, and then we're going to go to public testimony. So I'm going to ask about Intro 1001, the text messaging system on child health. What type of child health guidance and reminders, such as routine vaccinations, does DOHMH provide to parents, if any?
Good morning. Thank you for that question, Council Member. We provide information on our websites. We also work very closely with H+H and provide public information in that way. We have a texting service through early intervention, and so we provide a lot of information with respect to milestones and vaccinations and things of that nature in those forums, and that's really the ways that we communicate that information.
Does the administration, either DOHMH, DOE, or other city agency, provide reminders to parents on deadlines for registration for schools, school-based programs, and childcare? If so, through what mechanism?
We don't do that, and I would defer to New York City Public Schools on that.
What type of communication and outreach does the administration perform regarding the availability of subsidized childcare in New York City?
I would have to get back to you on that.
Okay, please. Is there targeted outreach to communities that would benefit them the most? I mean, you'll give us both. Okay.
Correct.
How would the administration develop and manage a citywide automated text messaging system for child health reminders? What agencies would be best suited to develop this system?
We support the intent of the legislation. However, we don't think that we're the right agency for that kind of service. It would require a lot of coordination that we're not really set up to be able to execute.
Okay, what training, I'm going to switch now to intro number 1056. What training, if any, do school nurses and health personnel currently receive on the provision of LGBTQIA+ competent care?
I would have to defer to New York City Public Schools on the training that they provide their staff.
Okay. What potential barriers exist in ensuring all relevant staff receive consistent, high-quality training?
I'm sorry,
Still the school, all right, let me skip to something else, because you're telling me to go to New York Public Schools, so we'll figure that out. Intro number 1146, expanding newborn home visiting program. What are the existing neighborhoods or populations already served by newborn home visiting programs, and what has utilization been?
So we're saturating over 75% of the tree neighborhoods, and we currently are attempting to fill 59 vacancies for home visitors. We're, as Dr. McNatt had mentioned in her testimony, we're attempting to hire people who are fluent in Mandarin and Cantonese. We're also attempting to fill these 59 vacancies, and it can take us quite a bit of time to be able to onboard and train people to be prepared to conduct home visits. But we are committed to 100% saturation of the tree neighborhoods.
Okay. What metrics are used to track effectiveness?
With new born home visiting programs, we do assess reach, we assess the number of assessments that we provide, whether mental health services or mental health needs. We assess the visits in terms of notes and things of that nature, what's offered to families. and the number of visits that we conduct and the outcomes of those visits.
Are there any current plans to expand the program?
Yes, we would love to be able to saturate the tree neighborhoods by 100% and fill those 59 vacancies.
Is there a mechanism for participants in the program to provide feedback on their experience?
Absolutely. And supervisors of home visitors also conduct check-in calls with families of newborns and infants, and also assess their experience of their interaction with the lead home visitor.
How would the administration scale up the newborn home visiting program citywide under this bill? What staffing, funding, or outreach challenges might limit program expansion?
There are many variables. There's variables in terms of space. At this point, I think we are running out of space to actually have lead home visitors be present in a city building. We're running out of space for storage of equipment, so we provide new families with car seats, with pack and plays, with cribs, diapers, and we are running out of space for that as well. So in addition to just seating for new staff, we would also need storage space for all of the materials that we distribute.
So DCAS doesn't have any space?
They do, but we also we want to be nimble. So if we have things in storage, it might take some time to be able to have it in place so that we are able to distribute it as needed.
Have you been in contact with DCAS, or?
I would have to get back to you on that and contact.
Get back to us, because if we
leads.
need to, if we, the council, needs to contact DCAS about that, we can do that.
Absolutely.
Okay, great. Does DOHMH or H&H provide standardized guidance to healthcare providers on how to work with and treat pregnant individuals who have opioid use disorder and the use of opioid agonist therapy?
Yes. As Dr. McNatt had mentioned in her testimony, we did release a health advisory in December of 2024, advising clinicians all over New York City of the data and recommendations to address the prevalence of overdose as a cause of pregnancy-associated death, and non-stigmatizing ways to approach substance use disorders in pregnant people. And as a department, we are working with the state to provide revised non-stigmatizing guidance on Capta Cara, the federal regulation that requires the creation of safe care plans for newborns who may be impacted by substance use from their families or caregivers, and supporting the birthing person. The department also has partnered with birthing hospitals and centers in the city to ensure understanding and implementation of the guidance. And this guidance also includes conducting universal verbal screenings using a validated tool for substance use disorders, and comorbid mental health conditions with fully informed consent following New York State guidance. Also avoiding stigma and missed cases by not limiting substance use screening to pregnant people with disruptions in prenatal care and or prior adverse pregnancy outcomes, and ensuring that the toxicology or biologic testing should only be performed with fully informed consent and as a therapeutic tool of medical treatment for pregnant and postpartum people or their infant. And finally, encouraging clinicians to initiate buprenorphine or methadone for pregnant people with opioid use disorder as soon as possible, so timely referrals to opioid use treatment prescribers can be made.
What obstacles could impact effective outreach to both providers and the public?
I'm sorry, could you repeat that question?
What obstacles could impact effective outreach to both providers and the public?
I would have to get back to you on that question.
Are neighborhood health service centers already distributing opioid antagonists such as Narcan, or offering similar education material?
They are.
Okay. All right, now I'm going to ask, I'm actually going to go back to intro 1042. Who administers the mandated trainings for DOHMH inspectors?
It depends on the training. So as I noted with Councilmember Sanchez, we do extensive training for our inspectors as they arrive as new employees, and the ongoing in-house trainings that we conduct that their supervisors, the Bureau of Child Care conducts for those staff. And then there are trainings that all city staff are required to take, and then there are optional trainings for professional development for health department employees. So it varies.
Does the administration currently track and monitor the types of trainings provided to child care inspectors?
So the mandated trainings are tracked, but
Okay.
optional trainings would not be.
Interesting, okay. What challenges exist in reporting on the frequency, type, and substance of such trainings?
So our concern is because of the, really the extensive nature of our training. We really want to reduce any administrative burden on a focus on reporting rather than a focus on conducting those trainings and our work to promote safe environments for children in childcare.
Are there current systems in place that track training compliance, and if so, are all current DOHMH inspectors in full compliance?
There are different mechanisms for tracking mandatory trainings. I'm not able to say at this moment whether all of our staff are in compliance with all of the very many trainings that we take as city employees.
Can you get back to us on that?
We'll get back to you.
Okay, great. All right, that is all the questions that we have. One.
I just wanted to clarify, you might not have this information today, but regarding just a follow-up on the chair's questions regarding administration of trainings, can you share the universe of, right, as a fraction, the universe of providers that have DOHMH, are licensed by DOHMH, and how many of them took the specific training that you described around opioid prevention, overdose prevention? Thank you.
On the second part, how many of the child care providers took the naloxone training that we offered? The 1,500. There were about 1,500 staff who took advantage of that training at the time, at our initial offering of it. But I will say that those trainings are available on an ongoing basis from the health department, and we have continued to remind providers of that availability, and they can be taking those on their own.
Yeah, just to add to that, so we have a really easy to access portal. I know I've signed up before joining the health department. I've signed up and gotten naloxone training on there. So we deliver it both in English and Spanish so far. If we find other people who can do training in other languages, we look forward to expanding as well. We did 164 public trainings and also have worked very closely with about 1,000 locations across the city who are trained to do trainings as well, to make sure that they're readily available and that kits are available both through our website and then also in local pharmacies, in the settings that people are able to access training, and really just try to blanket the city with access and training.
Okay, so it's 1,500 that you know of, but it could be more. And you don't have the universe of staff, I guess, if you're counting 1,500 staffers?
I'm sorry, would you repeat the question?
The number of total licensed childcare facilities and then the number of staff.
I don't have the number of staff. There are 2,200 child care centers. I don't know the staffing off the top of my head.
Thank you.
Any other questions, Councilmember? No. Okay, wonderful. Thank you so much to this panel. We really appreciate the administration's testimony today. Thank you. So we're now going to move to public testimony. I'm now going to open the hearing for public testimony. I want to remind members of the public that this is a government proceeding and that decorum shall be observed at all times. As such, members of the public shall remain silent at all times. The witness table is reserved for people who wish to testify. No video recording or photography is allowed from the witness table. Further, members of the public may not present audio or video recordings as testimony, but may submit transcripts of such recordings to the Sergeant at Arms for inclusion in the hearing record. If you wish to speak at today's hearing, please fill out an appearance card with the Sergeant at Arms and wait to be recognized. When recognized, you'll have 2 minutes to speak on today's legislation. If you have a written statement or additional written testimony you wish to submit for the record, please provide a copy of that testimony to the Sergeant at Arms. You may also email written testimony to testimony@council.nyc.gov within 72 hours of this hearing. Audio and video recordings will not be accepted. We will now, okay, great. So that, I'm going to call the first panel. There's one person? Okay. So the first person is Onandina Hawthorne. And before you begin, I just really want to personally thank you for being here and sharing your story. So you just press the, yes, the button when it's right. Thank you.
Thank you. Good morning, members of the Health Committee. Thank you, Chair, although she's not here right now, Lynn Schulman, for having me today, and to our Councilwoman, Julie Menon, thank you so much for introducing Intro 895. And thank you to the New York City Department of Health for their work as well. My name is Dina Hawthorne, and I'm a healthcare professional, a special educator, a mother, the co-founder of the Elijah Alavi Foundation and president, and importantly, I am Elijah Alavi's mother. November 3rd of 2017, I dropped my son off at a licensed childcare center here in New York City, trusting they would keep him safe, based on their assurance. They shattered my trust when they gave my son, with a documented and known severe food allergy to dairy, a grilled cheese sandwich, and worst, they dismissed his symptoms. And although they assured me they knew how to act in the event of an emergency, they did not administer epinephrine. Staff was not trained to recognize the signs of anaphylaxis. There was no urgency to act quickly. My son, Elijah Alavi, was only 3 years old, and he died based on what they failed to do. Act quickly. Identify the signs and symptoms of his food allergies. They were incapable of doing so. I buried my child over something that was and is preventable. I'm here today to urge you to take action. It is time we create standardized safety measures on how to act in the case of an anaphylaxis emergency, and how the ability to identify the signs and symptoms of a food allergy reaction in infants, children, kids, in their learning environments such as schools, daycare centers, home daycare spaces, aftercare, etc. The bill number 895 builds on the foundation of Elijah's Law by expanding its protections citywide. I love this city. I was born in this city. Thank you to
Please continue.
Okay, thank you. Thank you to Councilwoman Julie Menon for your work in this important legislation. This critical legislation would require the Department of Education to stock weight-based dose epinephrine on all school premises. More importantly, mandate that all child care programs are equipped with stock weight-based dose epinephrine for children, and also ensure legal compliance and preparedness trainings in how schools and centers respond to life-threatening allergic reactions. This is important because when it's voluntary, they don't have to do it. And so we thank you for considering this to be mandatory. This is a life-saving prevention policy. It ensures that every child is protected. This legislation will give caregivers the tools and training to act and give parents assurance these facilities can actually take good care of their children and all other children in their temporary care. Food allergies can be fatal. Let's prevent temporary care from becoming permanent sorrow like me. Passing Bill number 895 is how we honor Elijah Alavi's legacy, and not with words, but with action. I, with a grieving heart and a passionate spirit, urge this Health Committee to pass this bill and help protect one of our most vulnerable population, children. Thank you for giving me this opportunity.
Thank you so much. I really can't thank you enough for having the courage, the bravery to fight on this issue. You are literally going to be saving countless of children's lives. You already have with Elijah's Law, but you're continuing to do so by making this mandatory and by speaking out. And I can assure you that we will honor Elijah's memory by passing this law into the council and making sure that no other child in New York City suffers from the same fate. So if it's okay, I'd love to ask you a few questions.
Yes.
First of all, the child care facility that Elijah was at, so they were aware that your son had a life-threatening food allergy, correct?
Yes, that is correct. Thank you for that question, Councilwoman. Yes, they were fully aware. And it was documented he had an IEP as well.
And did they say that they knew how to utilize an EpiPen if needed?
Thank you for that question. Yes, they did.
And by passing this law, Intro 895, by making it mandatory that every single school and child care facility, whether it be a public, private, or charter school, would have to have the EpiPens on site as well as the training, what impact do you think that that is going to have in terms of preventing these horrible casualties?
Thank you for that question, Councilmember. They won't have to sit here in this chair. A parent wouldn't have to sit here. When things are voluntary, that means you don't have to do it. When things are voluntary, it gives that crack, that loophole. And unfortunately, it allows for something that is preventable to be cast to the side and question if the importance of doing the thing. So taking care of children with food allergies, it's not going anywhere. And so passing this bill will ensure that the training is happening and that there's a standardized practice of safety measures that are taken that's not put it on the back burners of just the parents alone, but also everyone involved, because the children cannot speak for themselves.
Right.
And so to make it mandatory, it would allow the parents to have that assurance that their children are safe and that there are important protocols in place to ensure that safety.
Absolutely. And as you and I have discussed, one of the challenges with food allergy is when your child is going through anaphylactic shock, they, to your point, cannot communicate that. They can't breathe and they can't communicate what is happening to them. Councilmember, do you have any questions?
You know, I just want to join in thanking you so much for your advocacy. My son is 3 years old, and I just can't imagine what you lived through, but you're saving my son's life, and you're saving so many families. So thank you for this advocacy.
Thank you.
Thank you, Dina, so much for being with us today. We really appreciate it. Thank you.
Thank you for having me.
Okay, I'm going to call the next panel. Judith Narain, Catherine Trapani, Denise Carter Pruden, if you could please come down. Thank you.
Thank you very much, Councilmember. Unfortunately, Ms. Noreen, I believe, had to leave, but I'm happy to be here. And with gratitude to members of the Health Committee, I know you have a lot on your agenda today and very important issues. My name is Catherine Trapani, and I am the Assistant Vice President for Public Policy for Volunteers of America, Greater New York. We have 6 emergency domestic violence shelters and 1 Tier 2 domestic violence shelter, and we serve a large number of survivors in our family and women's shelters across New York City. I'm here to speak about Intro 29. In 2002, we partnered with Dr. Edie Zussman and Safe Living Space to start a groundbreaking initiative implementing routine brain injury screening for all survivors of domestic or intimate partner violence at our 7 domestic violence shelters. Using a trauma-informed approach and protocols developed in consultation with Safe Living Space, staff assesses all heads of household arriving at our DV shelters for histories and symptoms of brain injury. Those with positive signs are connected to brain injury specialists at partner hospitals who are able to provide diagnostics, services, and treatment. Over half of our survivors are reporting some constellation of a history of injuries associated with TBIs and symptoms, and it is clear to us that broader screening protocol would help many more survivors understand their injuries and get the care that they need. I want to make clear with respect to Commissioner DeCarli's earlier testimony that strangulation is certainly a leading cause of TBI in survivors, but it's not the only one. Many of our survivors report shaking, which causes a whiplash effect and could result in TBI being thrown into walls and blows to the head and neck. So I apologize for the graphic testimony, but I feel it's necessary to build on the good work. We are members of the Strangulation Roundtable, and we partner with NGBV, but we want to go further. Majority Leader Farias' bill would go further. Intro 29 would require the city to provide training to first responders and service providers about the connection between DV and traumatic brain injury, and I think would have a really profound effect. I do want to state for the record that we are submitting written testimony with a letter of support signed by certain anonymous survivors that couldn't be here to tell their stories, as well as service providers, legal providers, and others. So we've built a really strong coalition that I'm quite proud of. And so I really thank you for hearing this bill on a very busy day, and welcome my colleague Denise to talk about what happens at the program level. Thank you.
Thank you.
Oh, good. My first time here. I've never been to City Hall. So this is indeed a pleasure, and thank you to the members of the Health Committee this afternoon. My name is Denise Carter-Pruden. I manage a 120-bed facility in the Bronx. It is a domestic violence shelter. I've worked with VOA for the last 23 years, and the last 10 years I've ran DV programming. I'm honored to be here this morning in front of this committee to talk about what it means for our DV survivors to be identified as having suffered brain trauma. As I said, I've been at VOA for the last 23 years, and over the last few years, we've taken a unique approach to working with survivors, where we not only assess for the psychological trauma of abuse, but also for signs of brain trauma. Survivors begin to understand, I'm so sorry. So often survivors who come into our shelters have been told by their partners that they're crazy, that their injuries they suffered weren't bad, that they're exaggerating, that they're stupid, disorganized, bad parents, anything under the sun. All right? In DV situations, abuse is routinely minimized and dismissed, and its after effects are also minimized and dismissed. Survivors suffering from brain fog, tiredness, headaches, anxiety are made to question what their bodies are telling them and to ignore the signs and symptoms. Our survivors, on a daily basis, they put on a really brave face, not for their kids, but for shelter staff, for themselves, for people they encounter. When you are able to work with a survivor to discern what some of their symptoms may be due to, that some of their symptoms may be due to a brain injury, it can be transformative.
If I can just ask you to wrap up, please.
Okay, thank you
so much.
So just quickly, I'm going to run to the last segment of this. Within the last 2 months, clients KJ, NW, and CS have been strangled, hit on the head with fists and objects. They've lost consciousness, loss of memory, and difficulty recalling events. They were referred to proper screening by VOA due to conversations around TBI. So we're grateful to the City Council for hearing this legislation today and hope that you can move this bill forward so more survivors like KJ, NW, and CS can get the help that they desperately need.
Thank you very much. Thank you to, no questions? Thank you. Thank you to this panel. Thank you very much. I'm now going to call the next panel. Jade Donnelly, Heather Butts, Jahelia Joseph, Bob Pezzolesi. Okay, please begin. Thank you.
Well, thank you to Chair Schulman and members of the Committee on Health. We're grateful to be here to speak on the expansion of the newborn home visiting program. I would also like to give a special thanks to Councilwoman Selvina Brooks Powers for championing this issue. I'm Jade Donnelly, Director of Community Affairs at Nyasha's Promise. Nyasha means grace, mercy, and kind-hearted, which guides everything we do. Since 2023, we've partnered with medical and holistic professionals to host maternal health workshops and community baby showers to support expecting mothers experiencing homelessness in New York City. We have worked with shelters, hospitals, and social workers to bring resources, education, and celebration to pregnant mothers in transition. We applaud Speaker Adrienne Adams for creating the Maternal Health Steering Committee, a key move towards meaningful systemic accountability and equitable maternal outcomes. This is a powerful example of leadership rooted in care, and it brings hope to the many families who have been overlooked for far too long. Many mothers face pregnancy and postpartum with no support. There is a deep mistrust of institutional systems for fear of punishment, surveillance, or family separation. We fully support expanding the newborn home visiting program in communities of color and especially shelters. For many, timely support is life-saving, not optional. We want to stress that for this program to work, it must be rooted in trust. No mother should have to choose between care and keeping her family safe. If we claim this program exists to help, then it must deliver on that promise explicitly. For us, that means no hidden consequences and absolutely no risk of harm. The city must invest in maternal health. Not doing so means being complicit in maternal death. NYASHA's promise firmly believes that it is our and our city's moral duty and public health necessity because the cost of inaction is measured in lives. Thank you for your time and leadership and for protecting some of New York's most vulnerable. I'm happy to answer any questions.
Thank you. Yes, please begin. You just press the button and the red light will appear. Thank you.
Sorry about that. Hello. Thank you to members of the committee for the opportunity to speak today. My name is Heather Butt, and I am the chair of the Staten Island Hunger Task Force, a coalition dedicated to addressing food security for all Staten Islanders. Today, I am here to express strong support for Intro 1172, which would establish a pilot pet food pantry for 12 months. Food insecurity impacts not only individuals and families, but also pets. For many, pets are family. We are urging the pilot program to take place in Staten Island, New York. Our pantries have seen a growing number of clients struggling to feed both themselves and their pets. When forced to choose between putting food on the table and feeding a pet, some have excruciatingly difficult choices to make, which can involve surrendering an animal. This can be emotionally devastating. By supporting Intro 1172, the City Council is taking a step to keep families from making such difficult decisions. A pet food pantry will provide free, reliable access to pet food for those that need it. The pilot requires reporting requirements, which will also give valuable data, usage, cost, and impact. We urge the Council to pass Intro 1172 and to choose Staten Island as the site of the pilot program. Staten Island is ready and eager to host a pet pantry. Thank you for your leadership in this fight for food security.
Thank you. Next.
Good afternoon. I am Bob Pezzalezzi with the Interfaith Public Health Network, and I'm speaking in strong support of Resolutions 290, 294, and 442. The leading causes of death, disease, and preventable disability in New York are driven in large part by unhealthy diets. To build a healthier New York, we must adopt sustainable strategies to reduce consumption of ultra-processed foods and beverages, particularly those high in added sugars, sodium, and harmful chemical additives. Each of these resolutions rightly urges the FDA to strengthen its role in protecting the public from these preventable harms. We thank you, Chair Schulman, and all the resolution sponsors and co-sponsors for their leadership on these. With respect to added sugars, we look forward to the DOH-MH implementation of the Sweet Truth Law this October, which will require warning icons for high sugar items on chain restaurant menus. Relatedly, Resolution 442 supports this effort by calling on the FDA to require chain restaurants to disclose added sugars in their nutrition information. This would allow for fuller, more effective implementation of the Sweet Truth Act. Notably, industry leaders like McDonald's and Dunkin' already provide this information voluntarily, demonstrating that it is both feasible and overdue. Resolution 290 takes a complementary approach by urging the FDA to require warning labels on sugar-sweetened beverages, which remain the single largest source of added sugars in New Yorkers' diets. Additionally, growing bipartisan concern over chemical additives in foods highlights the FDA's ongoing failure to adequately evaluate the safety of many such substances. Resolution 294 calls for the full passage of the Food Safety and Chemical Disclosure Act, which passed the state Senate and nearly passed the Assembly this session. That bill would not only remove a small number of harmful additives, but more importantly, require public disclosure of chemicals that have entered the food supply through an FDA loophole without proper safety review. On behalf of our multi-faith, multi-sector coalition, we look forward to continuing our collaboration with the Council, the Center for Science and Public Interest, and other partners to advance policies that protect and improve the health and well-being of all New Yorkers.
Thank you very much. Next.
I just press the button. Can you hear me? Today I'm going to be speaking on Resolution 0116-2024, the resolution calling upon the New York State Legislature to pass and the governor to sign legislation that would establish the Medical Debt Relief Fund and allow taxpayers to make a donation to such fund on their personal tax returns. My name is Tahelia. I'm named after Mahalia Jackson, if you just switch the M to a T. I am a mother, a health justice champion, and a New Yorker. I'm here today to explain why this resolution is crucial from a reproductive perspective. I have the luxury of choosing whether or not to use birth control as a woman of childbearing age, regardless of whether you have public or private insurance. This is a privilege. I took advantage of this luxury by getting an IUD, which is also called an intrauterine device. It was liberating and practical for my way of life at the time. However, when it came time to have it removed, I ran into a number of complications that resulted in medical debt. Despite several office visits, provider changes, and healthcare facility visits, the issue remained, resulting in significant medical debt. My reproductive health was temporarily placed on hold due to this medical debt. Failure to undergo appropriate reproductive care, such as an IUD removal, could have resulted in fatal repercussions, such as infection or loss of reproductive organs. This medical debt relief fund resolution is critical because it will lessen the difficulty associated with postponing reproductive health care and help women who are unable to pay for reproductive care when their insurance does not cover specific procedures. This is why the decision to make a donation to this fund is beneficial and much needed. Thank you for having me here to speak on
Thank you very much. I want to
0116-2024. Thank you.
I want to thank the panel. Thank you very much for your testimony. Okay, now we're going to have, how does she pronounce her first name? Huh? Zoila? That's not what, oh. Okay. Oh, that's the dad, Antonio. Feliz Semboy, she's coming up too? Okay. She has to fill out what it is. Oh, okay. All right. Before you start, Councilmember Sanchez is going to read a statement. Okay.
Thank you, Chair. I will read in Spanish and in English. Buenos días. Nicolás Feliz Dominici era un niño feliz, lleno de amor. Cuando su papá llegaba del trabajo, me cuenta que corría a la puerta para darle un fuerte abrazo. Sus hermanitos lo amaban, los mellos, Oniel y Zoe. Todos adoraban a su querido hermanito de apenas un año. Hoy se cumplen 650 días desde que Nicolás, el lindo bebé de Zoila y Otoniel, falleció en su guardería tras haber sido expuestos al fentanilo. Otros 3 niños también fueron expuestos, pero lograron recuperarse. Tras una persecución internacional, los criminales que le arrebataron la vida a Nicolás fueron capturados y han sido sentenciados a casi 100 años de prisión federal, con más cargos pendientes en la Fiscalía del Bronx bajo la fiscal Clark. También el nombre de Nicolás vivirá para siempre en la esquina de Kingsbridge Road y Kingsbridge Terrace. Pero necesitamos más. Fundé la Alianza Comunitaria por la Seguridad del Oeste del Bronx, que une a todos los funcionarios electos y más de 100 organizaciones para impactar colectivamente la seguridad. Y hoy estamos impulsando un paquete de leyes para proteger a los niños en los centros de cuidado infantil. El 1041, que divulga información para padres sobre sus derechos. 1042, que informa y capacita a los inspectores. El 1043, que también divulga para asegurar que el personal esté capacitado en prevención y revención de sobredosis. y la 804 del concejal Abreu, que crea un programa de antagonista de opioides en guarderías. Hoy, antes de ustedes llegar, el Departamento de Salud testificó que los inspectores ya están capacitando para detectar actividad narcótica y que se han distribuido antagonistas a todos los centros. Eso lo causó Nicolás. Hoy quiero agradecerle a ustedes, a Zoila y a Otoniel, quienes a través de su dolor imaginable están trabajando para proteger y salvar a otras familias. Estuve presente con ustedes en los servicios fúnebres de Nicolás, los acompañé a sus padres durante el entierro. Ahora que somos familia, y no quiero que sepan que no dejaré de luchar, incluso después de aprobar estos proyectos de ley, para asegurarnos de que el legado de Nicolás continúe protegiendo a otros niños por generaciones. Gracias a la presidenta Shulman y a la vocera Adams por mover esos proyectos hoy. En inglés. Nicholas Feliz Dominici was a happy child, full of love for his family. When his dad arrived from work every day, he would zoom to the door and give him a big hug. His siblings loved him dearly, the twins, Oniel, Zoe. They all doted on their beloved one-year-old baby brother. And now it's been 650 days since Nicholas, the beloved son of Zoila and Otoniel, died in his daycare following fentanyl exposure. 3 other children were exposed that day as well and thankfully recovered. After an international chase, the criminals who took Nicholas's life were apprehended and in the time since have been federally sentenced to nearly 100 years in prison with more charges pending with the Bronx District Attorney. And Nicholas's name will forever live at the intersection of Kingsbridge Road and Kingsbridge Terrace, but we need more. I founded the West Bronx Community Safety Partnership, which unites area elected officials and over 100 organizations to collectively impact safety in our community. And today, we're moving a package of bills to protect children in childcare facilities. These bills will expand outreach efforts so parents know their rights, will train inspectors, will conduct outreach to ensure staff are trained on overdose prevention and reversal, and they would establish an antagonist program to help prevent overdose deaths in childcare centers. Earlier today, as a direct result of the advocacy of the parents of Nicholas, the Department of Health testified that inspectors are now trained to look for narcotics paraphernalia, and that antagonists have been distributed to all sites on a one-time basis. Today, finally, I thank Zoila and Otoniel, who through their unimaginable grief are working to protect other families. I went to Nicholas's funeral services when my child was 1 year old as well. I stood by his parents during the burial. We are now family, and I will not stop fighting. I know this council will not, even after passing these bills, to ensure that Nicholas's family and Nicholas's legacy continues to protect other children for generations. Thank you, Chair Shulman, and thank you, Speaker Adams.
Okay, go ahead.
Hi, good morning. Good morning. My name is Otoniel Feliz Samboy, father of Nicolas Dominici. As a family, we try to turn our pain on purpose, trying to do something in the community to represent our son's name, like what we're doing right now, supporting the law to make changes who support the community, because Nicolas' case is not supposed to happen like that. Any children is not supposed to face danger like this. It's preventable, but at the moment this happened, we doesn't have any regulation exposed to the law to make any changes. But now we have Pirina Sanchez and a lot of council members try to do something different, try to change how our children are taken care of on the daycares, even on the schools as well. Any children is not supposed to face any danger, in special daycares. Daycares is supposed to be a place to be safe, to be healthy, to be happy. But it doesn't happen with my son and the other children sharing the room with Nicolas at that day. 650 days today. It's like the time is flying, but for us, it's like this happened yesterday. The reason we every day wake up and we try to go ahead, finding purpose, finding our dreams, is because we are still alive, we are still having family, or 4 sons waiting on home for us, and we're trying to do the best every day, like Nicholas is here. Nicholas is not here as a human, as his body is not here, but we feel his spirit with us. That's why I feel the power to go ahead, to wake up on my bed and face this room right now and put my words to try to make changes, because our children have to be protected. Our children have to have any person on charge of them gotta be the right person, because criminals is not supposed to take care of children, to cover any dark business. So as a city, we have to make changes to making sure the person who is in charge of any children of the city is the right person to this. And for example, we was facing the federal case with Nicholas because this happened, and we discovered the person who was in charge of Nicholas just had over 8th grade. It's like the person close to 40 years who got on the school on the last time around to 12 years. So this person wasn't on the school, wasn't prepared, wasn't ready to take care of children, because education, culture, preparation gotta be the priority one for any person who taking care of children, because a daycare center member or the person on charge of the daycare gotta be like a doctor, gotta be ready, gotta be prepared to take care of any children. Thank you for paying attention, and then I hope all the words and all the legislation and purpose right now make it count and make the Nicholas name alive. Thank you.
So, thank you. One, I want to, I'm so sorry for your loss.
Thank you.
And I want you to know there are people here from the Department of Health who are listening to this testimony, and we're going to make sure that we already have spoken to them. They've already made some changes in their training, but we're going to make sure that things like this don't happen again, and that we'll make sure that your child is going to be remembered in a way that he helped to make changes for this, so that other children don't suffer the same consequences.
Yeah,
and you
thank
have a wonderful council member who's a colleague of mine, and we're going to make sure that that happens. Okay?
Yeah, thank you.
You're welcome.
I want to put something facing right now, because I work for a airline, Delta Airline, at JFK Airport. To first touch any international bag, I have to go to the screening by the state and by the federal port authority. So I just touching bags, loading planes, and I have to be screening deeper. But this person is taking care of our children, and they don't have this screening. We want this make it count, and we screen every person who gonna touch children, because I think if our authority take care about bags of the passengers as a city, we have to take care about who gonna touch any children in the city.
Totally understood. Totally understood. Thank you
you.
very much.
Saludos, mi nombre es Zoila Dominici, la mamá de Nicolás.
Hello, I'm Zoila Dominici. I'm Nicholas's mother.
Como madre, para mí es difícil estar aquí.
As a mother, it's very hard to be here.
Porque él no está, pero tampoco quiero que las cosas continúen mal. Quiero que las cosas cambien.
Okay, thank you. Because he's not here. It's very hard as a mother to be here and him not being here, but I also don't want things to continue like this.
Nicolás tenía 1 año y 9 meses cuando murió.
When he died, Nicholas was 1 year and 9 months old.
1 año, 9 meses pasaron de que él se fue, de que lo llevé al daycare para que lo cuiden mientras yo buscaba un mejor futuro para trabajar.
He was 1 year, 9 months when I took him to daycare while I looked for work to give him a better future.
No fue fácil para mí confiar en alguien que nunca había visto.
It wasn't easy for me to trust in somebody that I hadn't seen before.
pero ese día pasó lo que ninguna madre desearía que pase.
But that day happened what no mother wishes for them to happen.
Fui a buscar a Nicolás y ya Nicolás no estaba en el daycare.
I went to pick him up and Nicholas wasn't longer in the daycare.
Ya estaba en el hospital y ya estaba sin vida.
He was already at the hospital without life.
Pero estoy aquí por él y por él he continuado.
But I'm here for him today, and because of him, I have continued going on.
No ha sido fácil cada día levantarme y ver que su cuna aún sigue vacía, que no llega.
It hasn't been easy to wake up every day and see that his bed is empty.
En ocasiones he soñado que me han llamado del hospital para decirme que ha despertado.
Sometimes I dream that they call me from the hospital to say that he woke up.
Pero para no caer en una locura he tenido que mantener mi mente ocupada.
But in order to not fall into madness, I've had to keep my mind busy.
Pero para no hacer la historia larga, quiero que esto sea mejor, que las cosas mejoren para los niños, que ninguna mamá tenga el miedo de que le pase lo mismo que le pasó a nuestro hijo.
But to not make the story long, I just want this to get better, to make things better, and that no other mother has to go through this.
Gracias.
Thank you.
Thank you very much. Tell her that we already talked to the Department of Health, and there are people here from the Department of Health that are listening to her. She understands English, or?
Yes, she does.
Okay. So we're going to do what we can, okay, to make sure that Nicholas is remembered in a special way, that we can make sure that that doesn't happen again, okay?
Thank you. Gracias por venir y testificar. Thank you, Chair.
Thank you. Have a good day.
Okay, next panel is Nadira Pittman, Sarah Fajardo. Oh, sorry, couldn't read it. Liliana DeLuca, Denise Gibbs, and Christopher Leon Johnson. Wherever you want to sit. Okay.
All right. Can I go? Hello, Chair Shulman, Chairs Areola. My name is Christopher Leon Johnson. I'm here to show my support for Robert Holden's bill to support pet pantries. I believe that this should start in Staten Island because there's a lot of pet issues over Staten Island, the forgotten borough. I believe that if you start in Staten Island, it's going to work. It's going to help everywhere else. I believe that the other 4 boroughs already have enough. It's a big population, but if you start at Staten Island, it gives the hope of this working. I believe that people that don't have a lot of money or who have to choose from paying their rent or paying their cat food, trust me, this happens in real life, they shouldn't be in that position. I believe that just like we all care about humans and the city and the government, the federal and the state does whatever they can do to feed people that are disenfranchised, like in the local with the food pantries, like of Campaign to Fight Hunger and City Harvest. I believe that they should be able to do this for the people that have pets, like through the ASPCA or ACC, one of these pet-related nonprofits. That's what I believe. I think that should happen the most in City Council. I believe that this bill, Robert Holden, is a common sense bill and should go through unanimously. Like I said, they need to allocate at least, for now, at least like $1 million and give it to these nonprofits to help do this program with the help of the City Council and the Speaker, Adrian Dill Adams, or our next speaker, Julie Menon. I know I can't be off record with that, but I'm calling on the City Council to really make this happen, try to get it passed through by this year, because I don't think that whoever would be council member for next year should be able to reintroduce this bill. So I think it should just go through fast track, probably at the end of the year. So I got a lot to go for. I got to go out outside. I know they let these people say, give them much time they can. So thank you so much. I support Bob Holden's bill.
Thank you. A couple things. One is that I'm a co-sponsor of the bill. Two is that the reason why we're hearing it today is so that we could get it passed before the end of the session.
Yes.
So I just wanted to let you know, but thanks.
All right, thank you, thank you.
Appreciate that.
Thank you so much.
Okay, next. Okay. You have to, hold on. You have, just so everybody knows, that because we have to be out of here by 1, that everybody has 2 minutes.
Okay.
So if your testimony is longer, you can submit it to us, and we'll read the whole, everything is read by the committee staff. So just wanted to let you know. Thank you.
Yes, my name is Liliana De Luca. I'm here to speak about a condition that is spreading very rapidly, and it's affecting thousands of people in the city and state of New York. This condition is called the Havana Syndrome. The Havana Syndrome occurs when technology is being used illegally on people for reasons of testing weapons and testing advanced technologies without consent. Those who are testing these weapons and technologies on the victims, they are from the 3 intelligence centers of New York, from the Intelligence Fusion Center of the City of New York, the Intelligence Fusion Center of the Hudson Valley, Rockland County, New York, and the Intelligence Fusion Center of the State of New York. This is causing brain lesions on the victims of this condition. Brain lesions that are tantamount to traumatic brain injury, and that cannot be reversed. So in the way that thousands of people are being used for these testing of these weapons and technologies, people, it affects their health, and it's something that cannot, there's no treatment for it.
Okay.
It's being done illegally against defenseless victims. And I know that you passed, for instance...
The 2 minutes is up, so do you want to summarize?
There's just one comment. I know that you passed the Post Act where the council received lists of weapons, including electronic weapons.
I'm sorry, we have to go on to other people, but thank you for your testimony.
Yeah, I wanted to mention that the use of these weapons have to be monitored.
Thank you. All right, next.
Okay.
Good afternoon. You have to press the button. Thank you.
All right, good afternoon. My name is Denise Gibbs, fondly known as Gaji Justice. I thank you for allowing me to be here. I've enjoyed this morning. I am a retired assistant superintendent of schools. I did supervise the nurses, and so I'm very familiar with the EpiPen. It's really sad to hear what has happened and what's been going on, but I commend you all for the work that you do. I'm talking about repealing Section 3024 of the Cures Act, the 21st Century Cures Act. And the reason I wanted to bring that to our attention, if I ask the question, can you, as an American citizen, be experimented on without your consent? Most likely you would say no, if we ask that to the general public. However, this section bypasses that right. This section allows a medical institution to hold an internal review board or an institutional review board meeting without the consent of the patient if they find that, number one, it will be minimal risk to the patient, number two, it will be a benefit to society, and they can include the patient in an experiment, which could include implanting them and and also communicating with the devices that they implant into the people. So it's, I'm just encouraging us to look at that act again, 3024 of the 21st Century Cures Act, and to repeal it, because no one, I don't think that the general population knows that they can be experimented on without consent, and I don't think anyone in this room would like to be a part of an experiment, considering the kinds of experiments we've had in the past.
Thank you. Next.
Good afternoon, Chair Shulman. Thank you for the opportunity to testify today. My name is Sarah Fajardo, and I serve as the Senior Director of Community Outreach and Advocacy for the Korean American Family Service Center. For over 35 years, KAFSC has worked to support immigrant survivors of gender-based violence, offering safety, healing, and hope through culturally and linguistically accessible services. I'm testifying today in support of Intro 29, a bill requiring a training program for first responders and an awareness campaign regarding DV-related traumatic brain injuries. At KFSC, we see firsthand how trauma from gender-based violence, domestic violence, sexual violence, and child abuse intersects with deep-rooted stigma around domestic violence and accessing supports for mental health in immigrant communities. Our clients, primarily Korean and other Asian immigrant women, often face isolation, shame, and fear when seeking help. Many have never spoken about their trauma until they walk through our doors. Language barriers, immigration concerns, and a lack of culturally responsive care in the mainstream health and mental health systems leave them with nowhere else to turn. That's why KFSC's trauma-informed mental health services are so essential. We provide trauma-informed counseling, bilingual case management, and clinical support tailored specifically to the cultural needs of the community. Our mental health team is often the first and only point of access for survivors seeking help, and the need is growing. The CDC estimates that approximately 38 million women have experienced intimate partner violence in their lifetime, and an estimated 60 to 92% of survivors have experienced facial or head injuries. Even mild neurotrauma can compromise cognitive functioning. TBI injuries are often undiagnosed for many reasons, including fear from survivors about safety implications of seeking help, restrictions by abusers on access to healthcare or other services, and an already existing stigma in many AAPI communities related to seeking mental health services. We deeply support this public awareness campaign and training, and we urge the committee to pass it swiftly.
Thank you very much. Okay, thank you to this panel. You're excused. Okay, Marilyn Galfia. We have a lot of people online testifying, so, but you're the last in person.
Marilyn Galfin, Voices for Shelter Animals. We support many of the bills today and will submit a longer testimony. We strongly support Councilmember Holden's Intro 1172, the pet food pantry bill. It's critically needed, as many New Yorkers facing financial hardship should not be forced to choose between feeding their families or their beloved pets or having no recourse but surrendering their pets to a kill shelter. Along with lack of access to other life-saving resources like affordable vet care, spay, neuter, dog training, so on, economic euthanasia rises. The city must invest in the life-saving solutions and legislative initiatives. Right now, we are in the midst of the biggest homeless animal crisis, abandonment, community cat, shelter overpopulation. The city needs to declare this a state of emergency and implement emergency protocols. This cannot continue as business as usual. Councilmember Shulman, after speaking to you face-to-face, your office has still been non-responsive to my calls and emails. The ACC is in your purview, and you can take immediate steps to help the shelter animals. I've sent you policy suggestions that could change as soon as today, and animal welfare initiatives, but still no response. Right now, in real time, there's about over 30 animals on the at-risk, which is a kill list. This past weekend, 10 loving, adoptable dogs, including puppies, had their lives taken from them. We can't go around saying this is humane euthanasia, this is killing. We're in a crisis. There'll always be people issues, but the city cannot continue to turn their backs on these animals. I have sent videos and bios to all council members, and if they haven't already looked at it, I asked them to please look at this heartbreaking reality and the gravity of this tragic situation. Advocates have long asked for Department of Animal Welfare and Animal Welfare Committee and other animal welfare initiatives. Nothing, zero. This crisis cannot continue to be put out of sight, out of mind. We need an emergency task force, in my opinion, a town hall meeting for community to work together. And I would like the council to consider legislative initiatives I have sent to everyone. No one convinced me the city cannot be doing better. It is simply that it's not a will to do that. Again, I implore that this city council and city government take this seriously and enforce and have like I said, a community meeting, and let's get together on working on this. I shouldn't have a folder of animals killed and keep growing that list.
All right, thank you very much.
We have solutions, and I ask that you please have a conversation with me.
Thank you very much.
Thank you.
Okay, we're now going to switch to virtual testimony at this time. Please wait for your name to be called to testify, and please select unmute when prompted. Also, I just want to reiterate to please keep your testimony to 2 minutes. We have a number of people who are testifying virtually, and we need to, there's another hearing in this room at 1 o'clock. So thank you very much for your cooperation, and I'm going to call Jenna Riemenschneider. Sorry if I mispronounce. Are you online?
I am.
Okay.
Starting time.
Good afternoon. Thank you for the opportunity to testify. My name is Jenna Riemenschneider. I'm the Vice President of Policy and Advocacy at the Asthma and Allergy Foundation of America, also known as AFA. AFA is the nation's oldest and largest patient advocacy organization, serving the over 100 million people in the U.S. with asthma or allergic disease, including more than 20 million people with food allergies. I'm here in support of Councilmember Menon's introduction number 895, which would require New York City schools and childcare programs to stock epinephrine. About 6% of children and adolescents in the U.S. have food allergies, with infants and toddlers ages 0 to 4 having a higher rate than any other age group. This is the equivalent to at least one student in every classroom with food allergies. Exposure to an allergen can cause severe reactions, including anaphylaxis and, in rare cases, death. Because there is no cure for food allergies, preparedness and immediate access to epinephrine are essential to saving lives. Epinephrine is the only treatment for anaphylaxis. In fact, children often experience their first anaphylactic reaction at school or in childcare settings, sometimes without a prior diagnosis. That's why it is so critical that these environments are prepared with stock epinephrine. AFA has long advocated for policies like this across the country, but this isn't just about policy, it's about preventing tragedies. As you heard from Dina Hawthorne, the death of Elijah Silvera, a 3-year-old who passed away after being given his allergen at a Harlem daycare in 2017, is a heartbreaking reminder of the urgent need for stronger safeguards in every setting where children learn and grow. We're proud to support this introduction alongside the Elijah Alavi Foundation, which honors Elijah's legacy by advancing life-saving policies like this one in New York and nationwide. When schools and childcare programs are equipped with stock epinephrine, they are prepared to save lives. Studies and real-world events show that stock epinephrine programs work. They reduce emergency response time, increase confidence.
Thank you so much. Your time has expired.
Can you just summarize the end? Go ahead.
Sure. And they increase confidence in staff and protect children at risk. So ultimately, this is good all around. So we thank you for considering this and making families safer in New York City.
Thank you very much for your testimony. All right, next is Chris Martinez. Is Chris Martinez there?
Thank you so much. I appreciate everything Jenna just said. My name is Chris Martinez, and I am President and CEO of the Foundation for Asthma and Allergy Impact and Rescue. Want to thank everyone for allowing me to testify today in support of 895, which again requires New York City to provide epinephrine both in the school setting as well as in childcare programs. We are a national nonprofit committed to ensuring every child is rescued at school, healthy at home, and connected to care. And in addition to providing many schools epinephrine, we operate a program called Rescue, the largest school-based asthma intervention in the country. We work directly with schools to stock life-saving medication, train staff, and track the impact both from a health standpoint as well as economically. In Illinois alone, this program has returned more than double the state's investment, saving over $4 million in avoided emergency costs and hospitalizations. This data proves that preventative medicine in the school setting reduces health emergencies and saves healthcare costs in the process. Or as we often say, it saves both kids and cash. And epinephrine is no different. Anaphylaxis is fast, frightening, and often unexpected, even in children with no documented allergies. According to an NIH article from 2018, based on scientific simulations of another very large city, the Chicago public school system, where over 372,000 students are looked at, a universal stock-only model of epinephrine provides, quote, superior value over a sort of combination model where children who already have their own prescription bring their own in and a stock is provided to fill the gap. The ability to respond immediately without delay is not a luxury, but a necessity, and it is the most cost-effective way to keep students safe as well. So by passing 895, New York City will lead with compassion, with science, and with fiscal responsibility. This is a smart, life-saving, cost-saving policy that will protect our most vulnerable children in our greatest city. Thank you for your time.
Thank you. Thank you very much for your testimony. Okay. Next is Renia Butler.
Good morning, good afternoon, whatever time it is. My name is Renia Butler. I am a food allergy parent, advocate, and ally, and I am here today to share a piece of my personal journey and to testify in strong support of Elijah's Law, Bill number 85, which requires New York City to provide epinephrine to schools and child care centers, which I believe should not only be considered but swiftly passed. In 2018, I gave birth to my first child at 9 months old. She was diagnosed with life-threatening food allergies to all of the top 8 allergens: milk, egg, wheat, soy, shellfish, finfish, peanuts, and tree nuts. As new parents, my husband and I were stunned and paralyzed by the weight of this diagnosis and unsure of what it truly meant for our family. It wasn't until I came across Thomas Silvera and Dina Hawthorne on social media that I began to understand the gravity of our new reality, the unimaginable tragedy they endured, the preventable loss of their beloved son Elijah due to improperly trained childcare staff shook us to our core. Since then, the Elijah Alavi Foundation and countless organizations have taken that pain and transformed it into purpose. Their tireless advocacy has saved lives and continues to protect children, mine, yours, and the other 3.2 million children in the U.S. living with life-threatening food allergies. Elijah's Law represents a critical step forward in protecting these vulnerable children and ensuring emergency preparedness in schools and child care settings. Requiring these institutions to stock epinephrine auto-injectors is one of the most effective, evidence-based measures we can take. It empowers teachers, administrators, childcare staff to respond quickly and confidently, because when an allergic reaction happens, every second counts. On behalf of the Elijah Alavi Foundation, Sebastian, and the sweet spirit of their son, Elijah Silvera, please act with urgency. The lives of our children depend on it. Thank you.
Thank you very much. Nadia Swanson.
Hello. Thank you, Chair Schulman. My name is Nadia Swanson, pronouns they, them, Director of Advocacy and Global Programs at the Ally Forney Center. AFC and the New York City Trans and Queer Political Advocacy Coalition are in support of Intro 628, 629, and 56. Culturally responsive care trainings to the trans community need to be normalized part of required core education and onboarding trainings received along with caring for people of diverse races and abilities. All of these trainings cannot be limited to only sexual and gender health clinic staff. It needs to be for all staff that a patient would interact with across all specialties and settings. Trans adults and kids need to be affirmed regardless of the type of care they are receiving. Trans New Yorkers already suffer from disproportionate lack of access to healthcare due to making an already difficult situation of navigating that system feel impossible. We don't go or just delay care. As a non-binary person who has chronic illness, I'm misgendered every time I go to the doctor's office and almost never asked how to address me. It is something I've learned to accept and roll off my back in order to get care, but that's a privilege. For most trans people, it's not that easy, and it's not something that we should have to endure just to get primary care, life-saving screenings, psych, specialty providers. For the youth we serve at AFC, a quarter of our youth report at intake that they do not have a source for medical care. If they don't have access to medical care, they'll stay unhoused for longer and are twice as likely to experience early death. Lastly, I want to name the 3 budget asks the New York City Trans and Queer Provider Advocacy Coalition and its 80+ members have that would directly benefit the goal of increasing affirming healthcare. We need the Speaker's Trans Equity Initiative to increase to 10 million so that trans leaders can actually receive the funding intended for them. This includes the Trans Equity Consulting Group that was mentioned before, that was founded by Cecilia Gentili, who got that fund in the first place. 15 million for a gender affirming care contingency fund and 10 million for LGBTQ unhoused youth. Thank you very much.
Thank you very much. Michelle Villagomez.
Hello, everyone. Before I begin, I want to express our deep gratitude to you for considering so many critical measures to protect the health and well-being of women, children, and vulnerable New Yorkers. We're honored to be included in this important hearing, and thank you for recognizing the intersection between human and animal welfare. Thank you for the opportunity to testify in strong support of Intro 1172, which would establish a city-run pet food pantry and pilot. We commend the council and thank you, Chair Schulman and Councilmember Holden, for recognizing the growing need for pet food assistance across New York City. For this program to succeed, it must be implemented with dedicated new funding. Running a pet food pantry is not free. It requires resources for food sourcing, transportation, storage, staffing, and outreach. Without proper funding, this effort could unintentionally strain animal care centers of New York City or other essential animal services. Pet food insecurity is a real and growing crisis. According to the Mayor's Office of Food Policy, 17.5% of New Yorkers, over 1.5 million people, faced food insecurity in 2023, outpacing the national average. For families with pets, this often means choosing between groceries, medicine, rent, or feeding a beloved companion. Since the pandemic, the ASPCA's community engagement team has provided food directly to struggling pet owners in all 5 boroughs. Through our partnership with the Food Bank for New York City, we've helped distribute nearly 3 million pet meals. Still, we cannot meet the need. We urge the council to allocate at least $1 million in the city budget for this pilot. This investment will allow for adequate staffing, food purchasing, and smart distribution, ideally in collaboration with existing food pantries or municipal service hubs to reduce stigma and improve access. This pilot can help keep families together and reduce shelter intakes. With the right support and community input, this program can be a powerful tool for equity, pet retention, and public health. Thank you so much for being so progressive and realizing that pets are part of our families. Thank you.
Thank you so much. Next person is Megan Carroll.
Hi there. My name is Megan Carroll, and I serve as a Community Engagement Coordinator for the ASPCA's Community Engagement Team. I appreciate the opportunity to speak to you today about this issue that directly affects thousands of New York City residents and their ability to care for and remain with their beloved pets. Our program's mission is simple yet deeply impactful: to keep people and pets together whenever possible. We know from research and firsthand experience that the human-animal bond plays a powerful role in both physical and mental well-being. For many of our clients, their pet is not just an animal, they are a source of companionship, emotional support, and unconditional love. Maintaining that bond can be life-changing, especially for those already facing significant personal and financial hardship. Through the ASPCA's Community Engagement Program, we offer a variety of support services, including the provision of pet food. However, given the scale of need across all 5 boroughs, our current capacity only allows us to provide pet food on a one-time basis per household. This typically covers an approximately 2 weeks of supplies, enough to offer short-term relief, but far from sustainable solutions. Every day we receive referrals from social service agencies and nonprofit organizations seeking urgent support for their clients. The stories we hear are heartbreaking. Many pet owners reach out directly because they do not have enough food to last until their next paycheck. Some have already run out of pet food entirely, In these moments of desperation, I've heard clients express that they've had to share their own meals with their pets, or worse, skip meals altogether, simply to ensure that their pets are fed. Time and time again, they tell me, I'll go without pet food or I'll go without food if it means I don't have to surrender my pet. These stories are not isolated incidents. They reflect a widespread and growing need for ongoing access to pet food in our communities. Wanting to do more, I began researching pet food pantries across New York City to better support the clients that we serve. Unfortunately, this search only revealed how limited and inaccessible these resources can be. With an estimated over 200,000 pet-owning households living in poverty in New York City, it is clear that demand vastly outspaces supply. The lack of accessible pet food assistance.
Can you please wrap it up?
Yep. In closing, I urge the council to consider the growing need for sustainable city-supported pet food assistance programs. By expanding access to the critical resources, we can support the well-being of both people and animals across New York City, keeping families whole, reducing shelter overcrowding, and honoring the profound connection between humans and their pets. Thank you for your time in this important
Thank you
matter.
very much. And if you have a longer testimony, you can submit it. You can submit it to us at testimony@council.nyc.gov. Okay, next is Kalman Bako.
Good afternoon. My name is Kalman Boko, and I'm the development coordinator for India Home, a nonprofit organization that is dedicated to addressing the needs of and empowering the South Asian Indo-Caribbean senior immigrant community in New York City. Thank you very much to Councilmember Lynn Shulman for holding this health committee hearing. In the course of providing essential services for South Asian seniors in Queens, India Home recognizes the growing problem of food insecurity among our community. A 2021 needs assessment by the Coalition for Asian American Children and Families found that 51% of Asian Americans in New York needed help accessing food, and 85% had recently changed their food habits. South Asians were the most affected, with 75% of Bangladeshis and 74% of Nepalis reporting difficulties in obtaining food. India Home is committed to addressing food scarcity in our community. We currently serve daily congregate and home-delivered meals, as well as run 2 different food pantries, which operate a total of 6 times a month. However, the continued operation of our current food pantry program places a significant burden on our team, requiring 4 staff and 6 volunteers each week to manage distribution, culturally appropriate packaging, and crowd control. With rising demand and stretched capacity, we are urgently seeking a more sustainable solution. We are looking to create an exploratory coalition of New Yorkers and nonprofits with the support of New York City Council members to investigate the possibility of creating a new AI food pantry initiative based on a model currently operating in Yuhua, Singapore. The deployment of AI food pantries would offer a more effective way to combat food insecurity. While current food pantries, including most of the 561 operating in New York, are only open once a week for 2 hours at a time, each one only serves an average of 2,371 people. With Coalition, we could successfully produce a pilot model that is scalable and replicable and could be duplicated across the city. The current AI food pantries operating in Singapore are open 24/7 without the need of human labor and include features such as AI-based inventory tracking, smart shelves, real-time restocking, secure facial recognition or app-based entry, and autonomous restocking systems. Over time, this model could save New Yorkers millions of dollars a year while reducing waste. We would like to invite the Health Committee and interested New Yorkers to discuss the creation of a pilot model, including designing a budget and supply chain and possible avenues for funding. Food insecurity in New York must be addressed using cutting-edge yet practical means, and we have the opportunity to make New York the first city in the country to reshape how cities support the most vulnerable. Thank you for your time.
Thank you very much. Next person is Namir Dahir. Namer Dahir, sorry if I mispronounced.
Health. My name is Naima Dahir, and I'm here on behalf of the Arab American Family Support Center. AAFSC provides culturally and linguistically competent, trauma-informed, multi-generational social services to New York City's growing Arab, Middle Eastern, North African, Muslim, and South Asian communities. Each year, we serve over 4,000 survivors of domestic and gender-based violence, many of whom come to us as the only trusted resource available to them. Through our anti-violence program, we offer safety planning, legal assistance, housing support, and the basic tools survivors need to escape abuse and rebuild their lives. We strongly support Councilmember Farias's bill, Intro 29, which would require training for first responders and service providers to recognize domestic violence-related traumatic brain injuries. This legislation heightens a critical but often overlooked issue, the connection between domestic violence and TBIs. which too often go undiagnosed due to limited awareness among survivors and frontline professionals. At our Family Justice Center sites across all 5 boroughs, we regularly support survivors living with the long-term effects of traumatic brain injury. In one recent case, a survivor was unable to recall key events surrounding her abuse due to a brain injury, a stark example of the consequences of miss and delayed diagnosis. Early recognitions of TBIs is vital not only in preventing further harm, but also interrupting cycles of violence and providing meaningful paths to healing. This issue is especially urgent for immigrant communities. Survivors of domestic violence, many of whom face immense trauma, now contend with an environment of heightened fear driven by xenophobic rhetoric and harmful immigration policies. These conditions have eroded trust in public systems and have made it harder for survivors to come forward, many choosing to stay in unsafe situations rather than risk interacting with authorities for fear of deportation or family separation. Federal policy change and proposed funding cuts, such as reductions to the Office on Violence Against Women, further threaten essential programs like ours. Against this backdrop, legislation like Intro 29 is not only timely, it is essential. Community-based organizations like AAFSC
Can you just, I need you to wrap it up. Thank you.
We are strongly responding to these challenges, but we need your support. So we want to ask your support in supporting this legislation. Thank you so much for the opportunity.
Thank you so much. And again, if you want to submit longer testimony, you can do that at testimony at council.nyc.gov. Okay? Thank you.
Thank you.
All right, I'm going to call out some names. If you're there, let us know, please. Sharon Leslie Brown, Eric Lee, Armando Rodriguez, Alex Stein. What? And there's no hands online. So you can say no hands online. Anyone in the room that hasn't yet testified, that wants to testify for the Health Committee hearing? No? Okay. I want to thank everyone for their testimony. There was a lot of legislation that was heard today. We really appreciate everybody who's testified both in person and online. And there's some very significant legislation here, so we're very appreciative of everyone that participated, and we're going to take a look at it and see what we're able to bring to the floor for a vote. And I will tell you that one of the things that I'm most proud of is the legislation to create a pilot program for a pet pantry, along with Councilmember Holden. And with that, I am adjourning this hearing. Thank you very much.